session ends, we can have our seats back. Thank you. The procession has begun. Please, we can stand up and welcome them. Thank you. The procession is being led by the registrar and CEO of the Institute. Thank you. Thank you. Yeah, thank you so much for the procession. Now, members, you can remove your cap and take a deep bow. Thank you so much. I think now you can return into your seats, the first row. Thank you. What a wonderful procession and colorful procession it was. Now, as we proceed with the conference, you permit me to invite the registrar stroke CEO of African Institute of Public Health Professionals, Dr. Ayodele Bankole James, for his welcome address. Thank you. Dr. Bankole, you're welcome. Please, can we clap for him as he comes?
The Honorable Minister of Health, the Chairman, Local Organizing Committee, Chairman, African Institute of Public Health Professional, Chairman, Institute of Research and Translation, Managing Director, Institute of Research and Translation, the Chair, Board of Trustees, Sexual and Reproductive Health and Rights, Rwanda. Member of Diplomatic Corps, distinguished member of African Institute of Public Health Professional, respected members of the media, here present, ladies and gentlemen. It is my singular honor and pleasure to welcome you to the 5th Annual Conference of African Institute of Public Health Professional. Fortuitously, this year, the conference holds in collaboration with Foresight Institute of Research and Translation and Sexual and Reproductive Health Rights, Rwanda. Distinguished colleagues and attendees, permit me to remind us that it was during the 4th annual conference held in Cairo, Egypt, November 2022, that a decision was reached to hold this year conference in Rwanda. You may like to ask me why. My response to this, considering the unique status of Rwanda as a hub of intellectual erudition and exchange in East Africa, coupled with a rich history of freedom of thoughts, accommodation of diverse opinions, and tolerance of critical thinking that led to the growth and development of mankind. Arguably, there is no better place to have this conference than Rwanda this year. Without missing a word, may I declare Rwanda supply us with all forms of mental and physical inspiration needed to power this conference. Distinguished participants, permit me to extend our sincere appreciation to you all for your resilience and doggedness exhibited by attending this conference in spite of the global economic downturn currently experienced the world over. This is a rare commitment to professionalism as health professionals on one side, and indeed humanity on a global scale of engagement. For this year tenacity, I hereby doff my cap. My dear colleagues, bearing in mind of this show of commitment, may I say with utmost tone of sincerity, I am very confident that you are going to make crucial contribution to the process of attaining a healthier and resilient community in our continent, Africa. In this way, you are going to serve the best interests of public health practice on the lives and soul of the African population. On this note, without any fear of letting you down, rely on our commitment in African Institute of Public Health Professionals. Gladly, I wish you a very fruitful and eventful conference. The African Institute of Public Health Professionals' vision of reducing diseases in Africa is bold, apt, and attainable. It is entwined to the Sustainable Development Goal 3, that is, ensure healthy lives and promote well-being for all at all ages. The Institute is focused on investing in the health workforce, particularly public health professionals in Africa. The theme of the conference is towards healthier and resilient community in Africa. We are proud to announce several distinguished fellows, scholars, and speakers who will speak on various aspects of the theme. The guest speakers include Our Excellency Ambassador Minata Samate Sesuma, the African Union Commissioner for Health and Humanitarian Affairs, Professor Wondi Alemu, International Health Consultancy, Atlanta, Georgia, and the Chairman, African Institute of Public Health Professionals, Dr. Nahema Hassan Al-Ghazal, WHO Country Representative, Egypt, Professor John Francis Mugisha, the Vice Chancellor, Cavendish University, Kampala, Uganda, Professor Nnodimele Onuigbo Achuluma, from the School of Public Health, Backup University, Elishan Remo, Nigeria. Professor Wagida A. Anwar, Hanshan University, Cairo. Professor Hayat I.M. Goma, Ahmadu Bello University, Nigeria. Andres Gitembagara, President, Rwanda Nursing Union. Professor Amani Abdullah El Sharif, Al-Azhar University, Cairo, and Vice President, Association of African University. Professor Babagana, the Honorable Commissioner of Health, Borno State, Nigeria. Professor Mustafa Mukhtar, Bayero University, Kano, Nigeria. Distinguished participants, be rest assured you are here for a real deal of both professional and intellectual feat. Let me felicitate with all the awardees and newly admitted fellows and members of the Institute. On behalf of the Governing Council, I sincerely welcome you on board as your host of service. State you are called to serve your country and indeed a larger continent in advocating and promoting the laudable heights of population-based service to prevent diseases and untoward health status and achieve healthy and productive living. Finally, African Institute of Public Health Professionals is happy to announce the implementation of series of capacity building programs on leadership and management for healthcare professionals across African continents. We are privileged to collaborate with frontline international agencies, among which is World Health Organization, on these notes. We look forward to having mutual collaboration with other collaborators and sponsors on this project. As we are all aware that healthier and resilient communities cannot be achieved on our continent without capacity building. We are all indeed committed to achieving all goals earmarked for the betterment of Africa and human race. Thank you so much, and God bless you all.
Thank you, our able registrar. Thank you so much. As he proceeds back to his seat, on your brochure, we are in the section of goodwill messages and opening remarks. You permit me to invite the DG of Rwanda Biomedical Center to come and give his opening remarks. Thank you. Please, as he's coming, we can give him a round of applause.
Good morning, all. Madam Tse. So, dear esteemed organizers, distinguished delegates, ladies and gentlemen, fellow advocates for public health, good morning again. So, we welcome you to Rwanda, and we are lucky to see that you have chosen to come to Rwanda. It's a pleasure for us. So I'm standing here on behalf of Director General of RBC, who couldn't make it, and myself, I'm Dr. Eric Remera, and I work in RBC as the head of research in data science. So today I'm standing here to deeply honored to inaugurate this momentous conference. And this gathering marks a pivotal moment in our collective journey to transform the health landscape of our continent, shaping a future where African communities thrive not just in the absence of a disease, but also in the abundance of the well-being. So the theme of this conference was well chosen as saying that it resonates also with the very essence of our shared mission. Our mission is to foster the healthier and more resilient communities across Africa. So this overarching objective encapsulates a multifaceted approach, demanding knowledge sharing, strategic planning, and unwavering collaboration among diverse stakeholders in the realm of the public health. So ladies and gentlemen, when you look at Africa, it has more than 15% of the world population, but only 2% of the world research outputs are produced in Africa. And even when you look at what's produced, most of the time it's produced by externals. So this gives us another task that we need to produce more, because we have a huge population to serve and to make sure that they are healthier. And the topic of this conference was well chosen as towards a healthier and resilient communities in Africa. So it's quite unfortunate that over the years in Africa we have had little contribution to the clinical research and outputs. And moreover, research and clinical research conducted in our continent, as I said, is sometimes conducted by externals. So the government of Rwanda, we are happy that you have chosen to come to Rwanda, and the government of Rwanda through Rwanda Biomedical Center committed to promote cutting-edge scientific research and data-driven solution through industry and academic partnership, internship, collaborations, and the promotion of evidence-based healthcare. So then, in the framework to improve the clinical research capacity, vaccine manufacturing, and achieve the African Union CDC goal of having at least 60% of African routine vaccine produced in Africa, Rwanda has initiated now the production of vaccine, and through the European Union supports, now we are now constructing or initiating the mRNA vaccine manufacturing, and this is starting very soon. So as we embark in this journey towards a healthier and more resilient community in Africa, I call upon each and everyone to join hands in this noble endeavor. It's not an easy task, but together we can and we will. So I salute this initiative of the African Institute of Public Health Professionals, and also congratulate all the fellows, and also thank all the partners who have contributed to this great event. So with no further ado, I wish you a good stay in Kigali and also a fruitful conference in Rwanda. Thank you very much.
Yeah, thank you so much, sir. Thank you. So as he walks back to take his seat, we invite the next speaker for his goodwill message, no other person than the Vice Chancellor of Cavendish University, Kampala, Uganda, dear Professor John Francis Mugisha. Thank you.
Thank you very much. The guest of honor of today's event, the members of council and our very able registrar of this body. Thank you. It is both an honor for me and a privilege to be addressing you, our esteemed guests and colleagues, fellows, members, and guests that have come here standing on the protocol that was outlined by the registrar. I wish, as a member of council, to welcome you to the 5th Annual International Conference here in Kigali. Like the previous speaker, I think the theme was very well chosen towards healthier and resilient communities in Africa. We do acknowledge that Africa is struggling, first of all, with coverage, health coverage. We are the least in terms of health coverage, least covered population, but also struggling with epidemics and worst hit by pandemics. We also have epidemic hotspots in different parts of Africa, especially in sub-Saharan Africa. So we do acknowledge the critical role each one of us plays in shaping the future of public health on this continent, and especially the African Institute of Public Health Professionals. Africa, with its rich diversity and untapped potential, faces unique health challenges, yet in these challenges lie opportunities for innovation, collaboration, and resilience. Our collective commitment to advancing public health is the cornerstone upon which healthier and more resilient communities will flourish. In the spirit of unity, let us leverage the power of interdisciplinary collaboration by merging insights from healthcare, academia, government, and local communities, NGOs, and international organizations, all present here, so that we can forge a path towards sustainable health solutions. Together, we can transcend borders and bridge gaps to ensure that the benefits of progress are accessible to all of us. Education, and especially health education, stands as a beacon of empowerment. Through continuous public health education and knowledge dissemination, we empower individuals to make informed choices, thereby contributing to the vitality of their communities. I would like to appeal to colleagues who are from the academia to make health literacy one of the generic skills for all students, regardless of the discipline they might be pursuing. Doesn't matter if they are studying telecommunication engineering or law or international relations and diplomatic studies or business. I think health literacy should be a cross-cutting skill that is needed now more than ever before. I do hope that this conference will serve as a catalyst for educational initiatives that will transcend geographical boundaries and address the specific needs of our diverse populations in Africa. As we deliberate on policies and strategies, we should not forget the importance of community engagement. Again, those of you from the academia, I would like to opine that we all become public health resources within the communities where we are located. Let's have, as a matter of fact, annual public health days, perhaps weeks. My university has an annual public health day, but we do activities for a week within the community, so that we become public health community resources. The resilience of a community is deeply rooted in its collective strength, shared commitment to well-being. By actively working with our communities and involving them in decision-making and health education and promotion, we can ensure that interventions are not only effective, but are also culturally sensitive and therefore more sustainable. I would want to conclude by extending my gratitude to each and every participant that is here for your dedication to the cause of public health, and particularly for building a healthier Africa and a more resilient Africa in the face of the various public health emergencies that we face. I do hope that this conference will be a platform for fruitful discussions, meaningful connections, and the birth of ideas that will prepare us towards cities in Africa. I thank you. I hope to learn and exchange ideas with all of you. God bless you.
Thank you once again, the Vice Chancellor of Cavendish University, Kampala, Uganda. So next, for our goodwill message, will be the Managing Director, Foresight Institute of Research and Translation, Hajia Kudirat Aderonke Adedeji. Thank you.
Good morning, the Honorable Minister for Health in Rwanda in absentia, the Director General, Rwanda Biomedical Center, distinguished guests, the Registrar, Africa Institute of Public Health Professionals, noble public health professionals, and also non-public health experts that are present here, eminent participants. I welcome each and every one of us to this occasion, the 5th International Public Health Conference at Nobleza Hotel, Kigali. And as we navigate complexities of healthcare in our communities, it is paramount for us to know the profound impact of social protection in promoting healthier and resilient societies. The amalgamation of a robust social protection system and also the public health initiatives stand as a linchpin for sustainable well-being across the African continent. From the ILO report in 2020 on social protection, we understand that social protection encompasses health care services and addressing the socioeconomic determinants of health, World Bank 2019. It is an instrument of social justice. It gives equal opportunity to other benefit health outcome, regardless of the socioeconomic status of any individual. This social protection play a greater role in resilience, in building resilience in the face of the health crisis. The recent global health crisis, talk of the coronavirus, the pandemic situation in some countries, particularly in African nations, recognize the pivotal role of social protection in building resilient communities. It also serves as a safety net during emergencies, and this ensures vulnerable populations to have access to health care and the essential resources. And this goes a long way to minimize the health shocks. From the United Nations report on sustainable development in 2020, efficient design social protection programs are a form of catalyst to achieve multiple sustainable developmental goals, particularly Goal 3, which is talking about good health and well-being, and also Goal 1, which is no poverty. All these contribute to the cycle of poverty, the breaking of the cycle of poverty and ill health. And this goes a long way to propel nations towards sustainable development. At Foresight Institute of Research and Translation, we take giant strides in this direction. We believe that our collective pursuit of healthier and more resilient communities is an essential one. We need to advocate for the integration and expansion of social protection systems across African continent. And this can be done by aligning our efforts, forging partnerships, and advocating for evidence-based policies. We all can realize the transformative potential of social protection in advancing public health agenda and also ensuring universal health coverage. Together, let's champion the cause of social protection as a fundamental pillar for fostering healthier, more resilient, and equitable societies in Africa. On this note, I implore each and every one of us to make a giant contribution in promoting social protection for us to achieve healthier, resilient communities. I welcome you all once again. Thank you for listening, and thank you for coming.
Thank you, the Managing Director of Foresight Institute of Research and Translation. Thank you. So, as we continue in this wonderful conference, we call on, is there any representative of Rwandan Nurses and Midwives Union? Any representative? Okay. Do we have also a representative of Her Excellency Ambassador Sisoma Minata Samante? Okay, maybe they're on their way. Okay, in the interest of time, we call on the keynote address 2, which will be focusing on health inequalities, the hallmark of health system in Africa, and will be taken by no other person than Professor Nodimele O. Atuloma, School of Public and Allied Health, Babok University, Nigeria. Please welcome him. Thank you. Yeah, please. How do we open the soft copy?
Good morning, ladies and gentlemen. Permit me to stand on existing protocol that the registrar established. Thank you very much. The title of my presentation this morning is Health Inequalities, the Hallmark of Health System in Africa. I'm going to take you on a journey back at the beginning. I don't think many of us are familiar with how the health systems in Africa was established. So I'm going to go back to the beginning to see how this inequality came about. Good. So on the screen, you would see the the PowerPoint version of what I'm going to present here. It's more like an outline. All right, so I would start off with the introduction. There will be no meaningful conversation on the theme towards healthier and resilient communities in Africa without the mention of the historical evolution of healthcare system in the African continent. What we are now experiencing inevitably has bearing on where we are coming from. It is said that if you forget your history, your future may be a confusion. Permit me to cite just one case in point as a typical event occurring during the evolution of the health system in Nigeria. So I'm going to use the case of the evolution of the health system in Nigeria, which typify the events occurring all over in Africa, in most countries in Africa. So a brief review of the historical evolution in healthcare in Nigeria will help us to understand how this inequality started. The historical development of the healthcare system in Africa takes the typical framework of colonial administration, which is common to most, if not all, African countries. The scope of my presentation will be defined by the theoretical and conceptual clarification involving these four key words: health, quality of life, inequality, and poverty. So I'll start first with the historical evolution of healthcare system in Nigeria. The evolution of medical healthcare service in Nigeria, and similarly in all of African countries, can be traced back to three convenient periods: the pre-colonial, the colonial, and the post-colonial eras. The pre-colonial era predominantly involved the practice of traditional care, such as bone setting, the traditional birth attendant, among others. However, these practices have persisted till today, with some recognition given to traditional birth attendants and included into the mainstream of healthcare at the primary care level. The colonial era spanned the period from the time of the colonial rule in 1854 down to about 1960. For Nigeria, we had the independence in 1960. Some had it before us, and some came after. Now, the earliest organized medical care was set up by missionaries as well as the colonial administration. Initially, this was around the coast of West Africa, with the establishment of hospitals in Lagos, in Abeokuta in 1859, military hospitals, and in St. Margaret Hospital in 1889. Now, this particular site today is the temporary site of the University of Calabar Teaching Hospital before they moved on to the permanent site. It must be mentioned that health services covering the general population was never the objective of the colonial era healthcare system. So we can see the beginning of inequality here. the healthcare system set up by the colonial administration was focusing on the colonial administrators, their military security personnel, and those who were working with them. Now, later on, the healthcare system, which was exclusively for this category of staff, was extended to families that served them. However, the missionaries provided limited health care, and this limited health care was intended to win those who they were presenting the gospel or any religious messages toward to. Now, we can see where disparity started from. Now, with the history of the development of health system during the colonial development, brought in some challenges which they observed after the colonial system started to develop. Now, the colonial health system spanned from 1945, that was the first 10-year development program to align and strengthen the healthcare from 1945 till 1955. Now, the second colonial development plan to strengthen development in Nigeria continued from 1956 till 1962. After the independence, the independence of 1960, the elected government took the initiative to establish the first national development plan. And this was a 10-year plan, or a five-year plan from 1962 to 1968. The second national development plan, again, to fortify what was left behind by the colonial administration from 1970 to 1975. The third national development plan, again, to fortify what was discovered during the second national development plan from 1975 to 1980. The third from 1980, another till from 2004 to 2008. Now, all of these five-year development plans were to consolidate the deficiencies that were observed during the previous years. Now, the plan was to provide coverage with the shortfall of manpower, medical manpower that was to took over from the colonial administration. Now, all the while, in the departure effort, in the desperate effort to provide the population of Nigeria with adequate health care, emphasis had been placed on curative medical care, with the resultant domination of the entire healthcare system by medical doctors emphasizing clinical care, for which they were trained, of course. Now, since the medical intervention had been the exclusive protocol in the previous development plan for healthcare over the centuries, we still have diseases ravaging the population of the world, including developing countries, and reducing quality of life for the majority of the population. Now, for this reason, a new paradigm of healthcare needed to be evolved, which is cheaper and more effective in correcting the errors of an exclusively medical approach to healthcare. It was in this recognition of the failure of past and existing healthcare system to provide satisfactory healthcare, that brought about the reform which introduced the primary health care. Health facilities, including human power resources, were inadequate. Inequality of distributed resources favored the urban setting rather than the rural areas. Now, this reform was geared towards redeeming the inadequate health resources and to increase the population receiving health care to at least 60%. This was the rationale for introducing the primary health care scheme. And the primary health care scheme was to provide opportunity for rural dwellers to receive health care. Primary health care, according to WHO, is described as health service essential to life, made universally accessible to individuals and families in the community by means that is acceptable to them through their full participation and at a cost that the community can afford. Now, this is a definition that establishes universal health coverage. And so the universal health coverage was the mandate of primary health care. But now, we are still suffering from inequality of distribution of wealth and resources, and focusing more on urban areas. I can imagine someone who is sick to have to travel to a particular health center to receive help. But the primary health care paradigm was to move healthcare to the people. Medical rehabilitation services, there are resources to be managed and quality output anticipated. Now, this means that the health system needed very, very expert managers. Now, this is exactly how the present health care system came to be, and there is room to evolve a more operational system. So there is still room for evolving an equitable health system. So let's quickly look at the establishment or the setup of primary health care. The concept of primary health care was formulated to provide essential health care based on principled, practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals and families in the community. Primary health care forms an integral part of the Nigerian social and economic development. I am using Nigeria as a case study here because I believe that every other country in this continent went through the same system of colonial administration, establishment of the health system, and the development that followed after until now. We are all familiar with the primary health care modality, which makes health services accessible, and we're talking about universal health coverage. But we're not getting the best of primary health care today. The reason being the beginning of the healthcare system already compromised the inequality. Just a side talk, the pre-colonial health services was indigenous, and it made healthcare available to anyone within the community. But when the colonial system was established, that healthcare system was despised and labeled inadequate. Now, let me quickly bring in the theoretical and conceptual clarification that underpin the title of my presentation: inequality. Inequality has always been there. And the trajectory of the historical development of the healthcare system from the entry of the colonial administration had the intention of inequality of service and established health care service for the administration and personnel with them who provided security services. And we can see where it is coming from. And with inequality, we see poverty coming in. Inequality translates to uneven distribution of resources. Much of the resources are distributed towards the urban area, and the rural areas are deficient. And this is one of the reasons why the healthcare, the inequality has translated to a problem that we are dealing with now. Now, the next concept I want to quickly mention is health. WHO has given us a definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. However, for this presentation, I'm going to take another conceptual angle to it. I'm going to consider health as a process of continuous adjustment, a dynamic process within the biologic environment of the individual to regulate and maintain a state of well-being such that any external disease-causing agent that interacts with the system will spontaneously produce an adaptive response to restore the original state of internal equilibrium. The dynamic adaptive process in the biological system can be disrupted by process from outside the internal biological system. In the situation that the body system, which includes all biochemical infrastructures and physiological systems, are unable to restore to the original internal equilibrium state, results in disease. Quality of life. Now, quality of life reflects the measure of ease with which an individual requires to accomplish necessities of life in all dimensions without external assistance. So the basic life processes, the basic life tasks that we can do confidently and comfortably, naturally, when we fail to do that, then the quality of life we have begins to diminish. Just like when there is an epidemic or a disaster, our health system cannot cope, and we need external assistance to provide us with the support. Right. I'm going to now bring up approaches to address diseases. We have two very basic approaches established. We have the clinical and the population health strategy. Primarily, disease burden has always been approached through clinical intervention, believing that the best way to address disease outbreak is by clinical intervention. No doubt this is true. The health system has developed over the years as a clinical paradigm since the colonial era, which is characterized by inequality. However, with the recognition of the value that can be derived from preventing a disease based on an understanding of the epidemiological framework of the natural history of disease pathogenesis and how feasible and easy it can be to track the disease before it attacks a person, has made it possible to have the prevention framework for addressing both communicable diseases and non-communicable diseases. Furthermore, with the recognition that the greatest burden of disease occur in countries with little or no resources to adequately address population health problems, provides the justification to apply a more cost-effective framework occasioned by public health. The two main official approaches for addressing health challenges today are clinical health and public health. These are distinct approaches and serve distinct functions. Clinical health is valuable when the disease has set in and symptoms are present and require treatment with medical and surgical intervention. However, population health or public health has its function focused on the pre-disease periods when prevention is possible and cost-effective. It was in recognition of the failure of past and existing healthcare system to provide satisfactory healthcare that brought about the reform which introduced primary healthcare. Now let's look at the approaches of health promotion and education. The main purpose of health promotion is to empower people to take full control of their health in matters related to helping themselves secure all that it takes to ensure quality life and in a community. Health promotion has been defined as any combination of health education and related organizational, economic, and environmental support for behavior of individual groups and community conducive to health. We need the primary healthcare system to be fully functional as originally established, with health promotion and health education as the first component of the three components of primary healthcare. It is because we have lost that goal and we have lost sight of the mandate that we are having a lot of inequality in the distribution of healthcare. Let me move on to health promotion in the control of disease in Africa. After decades of effort under the primary healthcare scheme, we still record unacceptably high morbidity and mortality. And we know that in 1989, the World Health Assembly in Ottawa Conference launched the health promotion movement. And that followed with the establishment of the primary health care in 1978. I want the diagram that shows us the level, yes. Now, I want us to focus on this. If we are going to have this universal coverage, we're going to have it at the point when the disease has not shown any symptoms. But once disease produces its symptoms and requires clinical attention, we're going to have the disparity continued. Clinical approaches are very expensive because the equipment, the technology is very high. But when we address the disease at the levels of prevention. We have the primary, that's the primary level. We have less to spend, and we can move information. That's under the health promotion. We have three aspects there. We have the health education, which was mentioned this morning. We have the service provision improvement, and we also have the advocacy, policy advocacy. Now, these are activities that follow under health promotion, and at this point, the symptoms of disease are not established yet. And then, as under primary prevention, we have the specific protection, which includes the immunization, nutrition, environmental prevention, yes, environmental sanitation, and all of those things that can be done that are the sources of the diseases that affect the community. But once we miss it at that point, at the primary prevention point, we are now going into the secondary prevention point. And this is where the emphasis is now. And then investments have been made. Serious investments are now in the secondary prevention level. But then we cannot say, forget the secondary, because most people already have, well, when I say most people, a sizable proportion of the community have already beginning to show symptoms of diseases, chronic illnesses, infectious diseases. They are all there, and they need drugs, they need medical attention to prevent them from getting to the tertiary level where disabilities may begin to creep in. But then we need to emphasize more investment and more commitment to the primary prevention level, which is cheaper and easy. For instance, health literacy, information about sanitation, and all the things that the individual can learn and do for himself. So I'm going to end this presentation with the keynote and recommendation. Now, our health system have been overburdened with communicable and non-communicable diseases for some time now. And if we continue this way without reform, we are going to have an experience that is more terrible than what we are having today. We are going to have epidemics of non-communicable diseases surpassing those of developed countries of the world. My keynote at this very esteemed conference of the African Institute of Public Health Professionals are: 1, if we are to attain or to advance towards healthier and resilient communities in Africa, there must be reform in the health system to eliminate inequality that has for a long time characterized delivery of health service to the population in Africa. Now, by eliminating the uneven distribution of resources, both financial and infrastructure, which is the major reason for the observed inequality that has put many of the population out of reach of needed resources to deal with basic human needs to improve the quality of life, which we know primary health care would have supplied. If we do not do this, then we're going to have problems. And we need to consider reforming the primary health care scheme as the paradigm for preventive health care practice, for which it was originally established, with more commitment and involvement. Any other consideration would be effort in futility. Thank you very much for listening.
Thank you once again. Your Professor Atuloma, thank you. As we proceed with the program of the day, you permit me to invite Dr. Chris Echiyo, the CEO of Rahi Medical Outreach, for a goodwill message. Dr. Chris Echiyo, you're welcome, please. Please, we can clap for him as he comes.
Message. I'm the CEO of Rahi, and we work in public health space, trying to provide medical care in rural Africa, with specific reference to the Niger Delta area. And I'm happy to be here, and I convey a goodwill message from volunteers and members of our organization who are working in that space. We're in total agreement with the Institute of Public Health in the areas of the gap that exists in public health. And it's a sorry situation in those riverine communities of the Niger Delta. Most of the issues that the professor just raised now are very, very germane and are issues that as a group we believe that partnering could help us resolve. So we've enjoyed a very wonderful partnership with the African Institute of Public Health, and we will continue to do so. And it's our great desire that as we continue to work across Africa, we'll be able to build and bridge the gap that exists with rural health care. Most of the things we've done, particularly with the global funding and global issues, are urbanized. The language we speak are for rural health care, but the deliverables are urbanized. And that's what we found out working in rural communities. So at the end of this conference, I think we should be taking home an emphasis that says that what we want to achieve should be more rural, even though it's global. They say global healthcare, but the challenges are really, really in the rural communities. Taking a cue from the last speaker, if we deal with prevention in the rural communities, we definitely will have less work to do in the secondary healthcare system, and more healthy people living in Africa. On this note, I want to welcome and thank you.
Thank you once again, Dr. Chris. Thank you. Now, you permit me to also invite Dr. Okolo Chukwumeze, the CEO of Right Place Health. Dr. Okolo, you're welcome.
I stand on the existing protocol, and I consider it a privilege to be invited to say a word or two. Right Place Health is happy to be part of this conference and to partner with the African Institute in some of the works that we are doing and we are champions within the African healthcare space. As the professor was speaking, the subject of healthcare inequalities and health inequalities of paramount importance in Africa. Of course, we know that there is a difference between health inequalities and healthcare inequalities. And he talked about the different stages and phases of prevention. In Right Place Health, we think global, but we also want to act local. And like the last speaker said, most of the of the effects of health inequalities and healthcare inequalities are seen in the rural communities. And in my opinion, most of Africa is rural. And so in most of our communities, we find pockets of these health challenges that need interventions. And so one of the areas that we think is important is in the quality of our water. Because we have looked at Africa, even looking at healthcare and health inequalities, and we found out that a lot of the diseases that we face are water-related. Either they are waterborne or water-associated, however you call it. And so our core message for this whole conference in Right Place Health is that waterborne diseases can be eradicated. And if we join hands, we'll be able to make things happen. So in the next day or two, as we have more time to speak, we'll be talking about these things and how we can make a difference. Once again, it's a pleasure to be here. I'm glad to connect with people of like mind as we rub minds and as we exchange ideas on how we can make Africa a better place and build healthier communities. Thank you very much.
Thank you so much, Dr. Okolo. As we proceed in the conference, it's my pleasure and honor to invite the moderator of this health inequality, the hallmark of health systems in Africa, who is going to take charge and invite the panelists. He's no other person than Dr. Suleiman Saidu Bashir. He's the executive chairman for Primary Health Care Development Agency, Nigeria. Please welcome him.
Distinguished special guests, dear panelists, good morning once again. Indeed, we have had the erudite scholar that delivered this well-articulated paper that is anchored on the attainment of the theme for this conference, building towards healthier and resilient communities in Africa. And during the course of the presentation, he has taken us through some very salient features on health inequalities, the journey of health systems in Africa. On this note, I want to invite the following panelists to also underscore the issues raised towards healthier health systems, healthier and resilient health system in Africa. Permit me, ladies and gentlemen, to invite Dr. Shamsuddin Yahya, a fellow of the African Institute of Public Health and the Executive Secretary, Katsina State Primary Healthcare Development Agency. Please take it. In quick succession, I also want us to welcome Dr. Jibrim Al-Qasim Musa, a fellow of the African Institute of Public Health, who is also the state coordinator, WHO field office in Taraba State. Let's put over a hand up. Give me a round of applause as he comes to take his seat. Ladies and gentlemen, let's also welcome Dr. Dotmi Doris Atimbie, another fellow of the African Institute of Public Health from the Department of Community Health, Bayelsa Medical University, Nigeria. Finally, but not the least, let's also welcome Michael Iodepun Olumaku of the National AIDS, STI and Viral Hepatitis Control Program, NASCAP, Federal Ministry of Health, Nigeria. Let's put up our hands as welcome. Okay. We have had the well-articulated paper that drew our attention, particularly from where we were coming from in the presentation, looking at the pre-colonial, colonial era, and after independence, using Nigeria as a model. 2 out of every 5 Africans are Nigerians. I think we have gotten a good example to use in carrying us through. And the presenter took us through some conceptual clarifications using inequity, health, and quality of life, and some historical evolutions, explaining the emphasis on curative health, the PSC reform, and how the current adjustment is needed to restore internal equilibrium, as well as the approaches to disease barrier using the health promotion approaches and the levels of intervention. And finally, he made a keynote that health systems are really overburdened with communicable and non-communicable diseases, and we need to check them now. And he also concluded with some key recommendations, I think, which will be the focus or the thrust of the discussion by the panelists. So maybe I think I will need to go down so that we can have the mic to inform the discussion by the panelists. Oh, do you have a second mic? Okay. So I think during the course of the presentation, he made mention of there must be action to eliminate inequalities that characterize the healthcare system. I want to ask on my immediate right, Dr. Shamsuddin Yahaya. You have been on the field managing the same primary healthcare system. What are the kind of inequalities that exist? We've gone far before the PHC reform. We've implemented it for decades. What kind of inequalities do exist in the system over there in Katsina State and Nigeria or Africa at large?
Thank you very much, Dr. Bashir, for this laying the background, and for the main presenter, Prof, for giving us an insight on the issues of health inequalities, which is hallmark of health system in Africa. Looking at the general picture, Africa, when you have a child born in Africa, he tends to be at a disadvantaged position because he has a 50% increased likelihood of having malnutrition. He tends to have, when you compare him with any other child born in any other continent of the world, he tends to have an increased risk of HIV. He's more likely to lose his mother due to complications of childbirth or due to HIV. Also, looking at the life expectancy in Africa, it's about 47%, which is lowest in the globally. Then sub-Saharan Africa is the poorest, with more than 50% of people that live in sub-Saharan Africa earning less than $1 per day. This is huge. And one critical issue we need to talk about is this issue of social determinants of health. These are very, very important issues that whatever we do, however we strive, if we don't address these issues, it's going to definitely affect and will
perpetually going to remain having these inequalities, social determinants, and this cut across issue of socioeconomic status, issue of access to qualitative healthcare delivery, talking about geographical access, looking at urban, rural, people that live in hard-to-reach areas, riverine areas. These are people that don't have access. They have inequality. Issue of financial access. I've talked about people generally in Africa are disadvantaged because they are poor, so they don't have the financial access to access quality healthcare delivery. So also socio-cultural access. A lot of cultural practices that are being practiced in Africa makes them to be having inequality. So there are many dimensions which we can look at, even some specific characteristics like the people that are vulnerable, the gender issues. These are all things that, have strong bearing in Africa. So what we need to, especially the speaker has spoken about primary health care. I think that is the way to go. We need to make sure that we strengthen and make primary health care functional. When we talk about functionality of primary health care, it's in terms of infrastructure. We need to have a strong infrastructure in terms of equipment, in terms of human resource for health, water supply, so many aspects. Once you make primary health care functional, it's going to address a lot of issues of access and inequality. People that dwell in the rural areas, in the hard-to-reach areas, are going to have both geographical, the financial access to these services. For us in Katsina State, our focus and main thrust is to have one functional PHC per ward, so that people will not have to travel for 30 minutes to access care. It's going to address issue of maternal deaths and so many other things. So I quite agree with the presenter that the way to go is having a functional primary health care level. Thank you.
Thank you very much. Indeed, a lot of the inequalities still exist and a lot need to be done. And Dr. Jibril Al-Qasim, you have been on the field, and the presenter also underscored the need to eliminate uneven distribution of health resources. You implemented this integrated disease service program. How can we go about eliminating this uneven distribution of health resources?
Thank you so much. The speaker has done justice to the topic, and it's very difficult to talk after the professor has spoken. But still, I think one can see one or two things. He has taken us through the vicious cycle of resource inequality, which is leading to health inequality, and the health inequality also leading back to resource inequality. Now, from the public health perspective, I think there are some initiatives that can be done which will reduce these health inequalities. The first and foremost is preventive care. Now, if we dwell more on preventive care, just like the Prof said, we may not need to go into the secondary and other levels of care. So preventive is very important, and I think that is the best way to go for now. Also other initiatives such as vaccinations. We know vaccination is one of the cheapest and most effective public health strategies. So we need to also strengthen that aspect so that we reduce the inequalities. Promoting the issue of the community health workers is also very important. Having the health workers in the community delivering health services to the communities. In Nigeria, we currently have the CHIPs, community health influencers and promoters. I don't know what obtains in other countries, but that community health approach is also very important to make sure that we reduce the inequalities. There could be the use of technology-driven solutions. I understand in Rwanda here, that they make use of drones to deliver drugs and consumables to a lot of areas. So that will also reduce the issues of health inequalities. Another important thing is having innovative solutions. Innovative solutions such as the use of telemedicine. In Africa, I think it's high time we embrace the use of telemedicine, which will bridge the gap in terms of the health inequalities. And also the use of mobile health clinics is also very important. We have to look also into reforming some policies. We have to advocate for policy reforms such that we increase the spending on health. Currently, the 15% that is recommended out of our budgetary allocation to go to health is nowhere to go by in Nigeria. Also, we need to strengthen the primary health care. We need to revitalize the primary health care system. And there has to be policies to reduce out-of-pocket expenditure. That is also increasing the gap in terms of the inequalities for health. We cannot also forget the issue of partnership and collaboration with governments, NGOs, international organizations. This will lead to pooling resources together and also sharing best practices and also implementing sustainable interventions. We have to empower the communities as well, because when the communities are empowered, there will be, for example, in Nigeria, I know we have the ward development committees, the village development committees. So such committees need to be empowered so that they promote health and also health prevention. And finally, I think we need to have a long vision to bridging this health gap, because once we create sustainable changes in the communities, it will lead to a long-term vision that will close the gap in healthcare. Thank you very much.
Thank you very much, Dr. Jibril Al-Qasim. Next will be a remark or response by Dr. Dotimi Doris Timbie on the issue of reforming the primary healthcare system, which Prof really itemized as a very key recommendation going forward in looking at addressing the inequalities in the health system. Indeed, where do we start from, and how do you go about any reform in the primary healthcare system?
Thank you very much. We know very well that primary health care is the only system that can really touch the masses. Most of this morbidity and mortality takes place in the suburbs, and most of the cases are not reported. So for us to have a real good reform, we have to look into the primary health care system. Who are the managers? Most persons that occupies primary health care, especially in Nigeria, don't have any business to do with primary health care. The reason is because they don't know anything about primary health care. But just because they have their godfathers in the political space, they bring them in, and they don't know how to go about it. And another thing is, those persons who are working at the primary health care centers, these are the people that relate to the communities. How well are they taken care of? How well are they monitored? If we actually want to address the inequality, let's start from the management and down to the service, those that delivers the service, and look at the primary health centers, the structures. Some of them look like shrines. Shrines. The structures has nothing to, in fact, nothing to write home about. Some of those structures, you find out that in some communities, they don't even have structures. Some are under mango tree, delivering their services. And then these persons that are taking care of, that are delivering these health services in the suburb, especially the community health workers, the community health practitioners that are there delivering these services, how often do we monitor their activities? How do we pay attention to them? He mentioned something like shortage of manpower. Go to some of those primary health centers. You just find one health worker there delivering the 12 components of primary health care, with partners coming here and there demanding for one data or the other, and you find those persons not being able to meet up When is the time for home rounds? When is the time for home visit to monitor the health of these persons? Well, it's not possible just because of these shortcomings. So I want to say that if we actually want to address primary health care, fix those persons that love primary health care. We are not talking about money here. There are people, a lot of persons occupying those positions, they don't have any flair or any love for primary health care. They don't know anything about primary health care. They are just there because they wanted, they are interested in the money because the whole world is going towards that area. So let's look into the management, look into those who delivers the services, and also the infrastructure. We try to fix it. Thank you.
Indeed, Prof has articulated a major mistake from where we started. We abandoned what we had and we adopted something and we are not fully implementing because it also created poverty in terms of. And we are looking at the inequalities, whether in terms of health status, whether in terms of access to health care, whether in terms of even the quality or even the experience of the care and the health risk that differ among the various groups. And how do we go about it from here? Maybe let me take final note, final words. We'll take from here, it will go down. Let's go straight to the point. Where do we start? Many things have been mentioned. And if we are going to do a reform has several control knobs. It may be in information, on governance has been underscored, financing has been underscored, is it service delivery? How do we go trying to move towards healthier, resilient communities in Africa using the primary healthcare approach to address the inequalities? Dr. Shamsuddin Yahaya, can we take your final words?
Yes, I think what I will say here is, like you have said, myriad of problems. So we need to foster and strengthen intersectoral collaboration to address those health determinants of social determinants of health. We can't do it in a silo. We at the health sector, we need to begin to work and speak with other sectors of the social sectors. For example, education, budget and finance, agriculture. Because if we don't address those root cause problems, will be going in cycle and cycle. So as we know that intersectoral collaboration is one of the key principles of primary health care, we need to begin to strengthen that collaboration and make it work so that we'll be able to address those determinants, social determinants of health.
The moderator said last word, but maybe I will use 3 words. Governance, leadership, and accountability. Once we get these 3 right, I think we are on the right path. Accountability most especially. People have to be held accountable to their actions in terms of service delivery, in terms of leadership, and in terms of governance. Thank you.
I want to add to what they have said. We'll also include monitoring and evaluation, and then we should learn to foster unity in the health system. The health practitioners will fight a lot. It's time for us to come together and prepare those, like what I learned in the US, you cannot go. Prepare those who can go to reach out to the community. Our passion should be the patient, and then we look for a way to help them. Thank you.
Ladies and gentlemen, the presenter has really done justice to this presentation, and the panelists have brought their various perspectives, their experiences, and public health practice to bear in the discussion that ensued. I think Prof, in his closing remark, he said any other consideration will be effort in futility. I was weeping within when I heard that in. But it also underscores the need for us to address these inequalities. Some of them have raised concerns or moral concerns. They ought not to be there. They are unjustified. They are preventable, and yet they still exist. They are staring at us. And with what Prof has presented and what the panelists have also tried to illuminate from their various lenses, I think it's up to we have this strong optimism that with the discussion that we have had, and we have various platforms of advocacy, we will go a long way in trying to make our own individual and collective effort towards healthier and resilient communities in Africa. Thank you very much for your audience. Thank you for the panelists.
Thank you, the moderator. Thank you, the moderator, Dr. Saidu Bashi. Thank you, the panelists, Dr. Yahaya, Dr. Jibrin, and Dr. Doris. Thank you so much. Now, as we proceed in the conference, it is my pleasure to invite the Registrar/CEO of African Institute of Public Health Professionals. Thank you. Dr. Bankole, you have the floor.
Good afternoon once again. Permit me to stand again on the existing protocol. Like I always say, it's a very strong platform that will not break. I mean the protocol, if all of us stand on it, it will not break. I remember during our second international conference in Uganda, when we wanted to do our investiture, Professor Mogisha said something. He said, this is the bottom pot. And of course, our women here, our mothers here, we know what is bottom pot. So, once again, you are all welcome. We have some that are not captured in our brochure. Nevertheless, we still get them inducted because it's an opportunity for them to be inducted. The next induction is going to be in Nigeria. And of course, it's going to be very expensive coming down to Nigeria. Our brothers and sisters are professional colleagues in East Africa. They want to be part of the bottom pots. Thank you very much. Dr. Jibril Al-Kazan, can you come out, please? Dr. Chris Ekiyo, can you come out, please? Dr. Doris, please can you come out too? And Hajia Mujana too, please, can you come out? You are the one to help us decorate or receiving, you help us to receive the new fellows into the institutes. Please come up, please. Those lists.
Permit me to stand on the existing protocol. It's strong enough, right? Yeah, thank you. The first on our list is Dr. Adamu Danladi Dawood. Please come forward, sir. Dr. Adamu Danladi Dawood is a public health physician with Bachelor of Medicine and Bachelor of Surgery degrees, Master of Public Health degree, and a certified management consultant, and also a fellow of the Institute of Management Consultants of Nigeria. He has completed several developmental courses, namely Advanced Health Management Program, Postgraduate Diploma in Public Health Management, and a diploma certificate in data processing. He holds a diploma in mental health and trained in Universal Treatment Curriculum for Substance Use Disorder, Colombo Plan, and also skilled in the Universal Prevention Curriculum for Substance Use Disorder. He's a holder of the African Vaccinology Course Certificate and Advanced Education and Research, and holder of Executive Diploma in Disaster Management. He served as a consultant in several international organizations, including WHO Afro-Region and principal as international consultant for pharmacovigilance for COVID-19 vaccines, and as a consultant epidemiologist to WHO, WCO, the Gambia. He's presently the project director for World Bank Accelerating Nutrition Results in Nigeria, projects as a non-state actor in Katsina State, Nigeria. He's a seasoned administrator and the founder, CEO of BioPrevent Consult Limited, and launched the Drug Use Disorder Intervention in Nigeria project in Abuja. He renders some voluntary services through BCL. He was a diplomatic volunteer technical aid corps to the government of Mozambique. He also voluntarily served as a member medical team, Federal Capital Territory 2016, and member National Medical Team 2015 Hajj operation, assisting pilgrims in a holistic and medical care throughout the period of Hajj. Dr. Dawood has been honored with several meritorious awards. Worthy of mention are the Certificate of Recognition for Contribution to the National Primary Health Care Development, COVID-19 Response in the year 2020, the Award for Excellence in Medicine, and an Icon of Humanitarian Service by the Arewa Youth Advocacy for Good Governance in Abuja, Nigeria. He speaks English, Portuguese, Hausa, and Nupe eloquently, with very fair understanding of Arabic and French. He is happily married with 4 children and listens to radio, music, play badminton, and swim when the time permits. Please, let's put our hands together for
On behalf of the Governing Council, fellow and other member of this picture. Come here.
Yeah, take a picture.
Congratulations, sir.
No, let's take another picture. You drop it and come and join
The next one on the list is Chukwuzoba Obinna Anthony. Please, can you come forward? Let's make him feel welcome.
Please, can we have Professor Mugisha here? Sorry, Professor Mugisha is part of the Governing Council of African Institute of Public Health Professional.
Relief services and national elimination program across many states in national and international journals. He is skilled in project management, research, data quality assessment, monitoring and evaluation, budgeting and training. Hence, he has organized, facilitated, and trained many healthcare providers on malaria case management, use of rapid diagnostic tests for malaria. He has also trained interpersonal communication agents in social and behavior change communication implementation. A lover of indoor and outdoor sports, he engages in watching and playing football during leisure, enjoys traveling, and loves music. Please, let's put our hands together for him.
On behalf of the Governing Council of the African and Fellows of the African Institute of Public Health Professionals, I present this meritorious award to you, Obinna Anthony, as a fellow of the African Institute of Public Health Professionals, for your selfless contribution to healthcare development and safety of mankind in your country, in Africa, and in the service of humanity. Congratulations.
You can join. Yeah. Congratulations, Obinna. Next, you permit me to invite Ms. Fehintola Olayinka Ejintumobi. Ajentumobi, sorry, please. Midwife from the defunct Ondo State School of Nursing and Midwifery, Akure, now Faculty of Nursing Sciences, University of Medical Sciences, Akure Campus, Ondo State, Nigeria. She is a certified registered nurse anesthetist from the School of Anesthesiology, University of Nigeria Teaching Hospital, Enugu State, Nigeria. She had a Bachelor of Nursing Sciences degree from National Open University, Nigeria, and Master of Public Health degree from Ladoke Akintola University, Ogbomoso, Oyo State, Nigeria. She is currently on her PhD in specialization in community health at Ignatius Ajuru University of Education, Rivers State, Nigeria. She has a certification in basic life support, advanced cardiac life support, neonatal resuscitation and critical care, including advanced trauma care and disaster management. Mrs. Olayinka has remarkable work experience in the primary, secondary, and tertiary health institutions within Ondo State, Nigeria in the last 30 years. She started at Basic Health Center, Imoru Ose, local government area of Ifon, Ondo State, Nigeria. Then proceeded to State Specialist Hospital, Nursing Services at Specialist Hospital, and then to Ondo State Trauma Center, Ondo, all in Ondo State, Nigeria. Yet currently, she is the Director of Nursing Services at the University of Medical Sciences Teaching Hospital, Ondo State, Nigeria. Earlier in life, she worked some years at State Specialist Hospital, Park Lane, Enugu, and National Orthopedics Hospital, Enugu State, Nigeria, just to mention a few. Iya Aje, as fondly called, is a mother to the core, an intelligent, multi-talented manager, and a disciplinarian. She has participated in professional examinations, coordinations, and marking with the Nursing and Midwifery Council of Nigeria. She has also participated in various mobilization in community towards health promotion, health education, and free surgeries for several years. She is a member of National Association of Nigerian Nurses and Midwives and a certified registered nurse anesthetist. Mrs. Olayinka is a devoted Christian and happily married to Pastor Felix Ajetunmobi with 3 handsome boys. She loves reading, cooking, singing, and sporting activities. Thank you.
Dr. Oladapo, is she around? Is she around? Please come. Coincidentally, she is Dr. Oladapo student. Yeah, so it will be an opportunity It was very funny when I went there yesterday. She was the one taking care of a lecturer in the room. So let us give her that honor to decorate our students.
I present this to Mrs. Ajetumobi Pentola Olayinka as a fellow of the African Institute of Public Health Professionals towards a selfless contribution to healthcare development and safety of mankind.
Thank you. Thank you. Okay. Next on, standing on the existing protocol, you permit me to invite your Professor Baba Ghana. Please, you're welcome, Professor. Please, you can clap for him as he comes to the stage. Thank you. Yes, Professor Ghana graduated from the prestigious Ahmadu Bello University, Zaria, Nigeria, with an award from the Pediatric Association of Nigeria as the best graduate in the year 1983. He was a demonstrator in anatomy in Newcastle upon Tyne Medical School in 1986. He was at the Institute of Urology, London, where he gained postgraduate diploma in urology in 1991. He was a registrar in urology at Dundee Royal Infirmary / Ninewells Hospital. Professor Ghana completed his specialist registrar training in South Wales / Royal Glamorgan Hospital and was appointed as a substantive consultant in Highwell Dar University Health Board in 2002. Your professor again has general urological training and special interest in investigation and treatment of benign and malignant prostate type of diseases, including using laser annihilation of the prostate, benign and malignant bladder type of diseases, such as blood in the urine, cancer of the bladder, incontinence using autologous sling grafting, urethral stricture type of diseases, including the use of buccal mucosa reconstruction. Yes, Professor again has wide type of the publications in peer-reviewed journals and has made several international presentations in San Diego University, United States of America, Montreal in Canada, Tokyo in Japan, and Khartoum in Sudan, and within United Kingdom. And Professor is a recognized medical educator and is a fellow of the prestigious Higher Education Academy of the United Kingdom. He is the current Commissioner of Health in Borno State, Nigeria. Welcome.
On behalf of the Governing Council, fellows, members of African Institute of Public Health Professional, I present this award to you, Professor Baba Malam Ghana, for your contribution to healthcare development in Nigeria, your country, in Africa, and of course, all over the world, for safety of mankind and healthcare development. Put your hand together, please.
Thank you.
Sorry, this is our first time of meeting, but before we decided to award Professor Ghana with our fellowship, we actually interviewed some of his staff from the state, Borno State, Nigeria. Of course, during his time, they are overwhelmed with activities, one activity to another. We are glad to be associated with you, and of course, together, we are going to salvage our country. We are going to salvage Africa. You are welcome, sir. Thank you.
Thank you, Professor. Standing on the existing protocol, you permit me to invite Fokukua Theopista. Fokukua Theopista. Please, we can clap for her as she comes out. Excellent obstetric care and management project in Greater Masaka region in collaboration with the Arusi OG UK. She has carried out several consultancies, baseline needs evaluation and assessment, process and end of project program reviews, and impact evaluations. Handled training over 8 years covering the fields of integration, decentralizations, and NGOs interventions. She has facilitated conferences, training workshops and meetings, proceedings for and on behalf of Human Resource for Primary Health Care in Africa, an excellent obstetric care project in collaboration with the United Kingdom funded programs. As we speak, she is finalizing her PhD program in population, family, and reproductivity of Ghana. Her program is being funded by HRP Alliance, part of the Health Organization, World Bank Special Program of Research Development and Research Training in Human Reproduction. This is a co-sponsored program executed by World Health Organization. She holds a master's degree in population and reproductive health and a bachelor's in health service management from Uganda Martyrs University in Nkozi. Theopista is one of the women that would like to see women around the globe develop into leaders. As we speak, she is on the management committee with the African Women Leadership course under African Leadership Transformation as South African funded organization. She has contributed and participated in a one-year mentorship program under HRP Alliance, World Health Organization. Apart from the above, she has contributed and participated in quality improvement and assessment of students' learning in high institutions as training and implementation of reproductive health services by the Global Health and Quality Assurance Training by Ugandan Blood Transfusion Services, the Community-Based First Aid Trainers course by Ugandan Red Cross Society, Basic Theory and Practical First Aid Training by Ugandan Red Cross, and Good Phlebotomy Practices at the Paragon Hospital, Kampala. She is highly experienced in leadership and organizational capacity strengthening and project implementation. She has been an active leader and member of the African Institute of Public Health Professionals and has presented at different conferences. Thank you.
This is the third conference of Africa Institute of Public Health Professional. Theopista is attending. We were together in Kenya, am I right? At our first international conference. We were together in Uganda at our second international conference. She was inducted in Uganda. This is the second induction. Yes, I will explain. Because she was not qualified for our fellowship as at then. We still have other cadre. We have associate, which is the list for people that, students that just graduated and are just working. And the second cadre, she key into second cadre, which is full membership. And now she's fully mature for the fellowship. Put your hand together for her. Yes, you can see what I did the other time. I invited Mrs. Feintola lecturer. So I still have Theopista Vice Chancellor here, who is going to present the plaque to her. Professor Mugisha.
On behalf of the Council, the Fellows, the members of the African Institute of Public Health Professionals, I present to you Theopista Fokukora, this meritorious award as a Fellow of the African Institute of Public Health Professionals for your contribution which is selfless to healthcare development and safety of mankind in Uganda, in Africa, and in the world. Congratulations.
Sorry, don't forget to pick your certificate of membership. The certificate of membership, those of you that are inducted today, or those of you we are inducting, don't forget to pick your certificate of membership. Thank you.
Standing on the existing protocol, you permit me to invite Mr. Moses Arinetwe. Please clap for him as he comes to the stage. Mr. Moses is a multi-skilled expert specialized in health and human resource for health system strengthening. He rose in the HRH field in Uganda health sector and served as the head HRH management, development and planning. 13 years after his early retirement from Ugandan public service, he attained rich professional expertise and experience in strengthening healthcare type of the policies, plans and systems at national and international level. He provides a technical support to international, national, and regional organizations as a consultant, technical advisor, member of technical teams, researcher. In this role, he has led in the development of several guidelines and policy strategic plans and fundable technical proposals in his area of health and human resource for health systems. Under short and long-term technical assistance to the World Bank, USAID, and the European Union, World Health Organization, and United Nations AIDS, he has supported in the development of fit-for-purpose institutional structures and systems, and advanced grant writing initiatives at country level. He has served as a senior visiting lecturer and spoke at local and international universities, including the Harvard University, Makerere School of Public Health, Uganda Matters University, Nkosi, and is presently a senior lecturer at the Ugandan Christian University School of Medicine, where he teaches health management and business skills for medical doctors. Moses easily adapts to and operates in quickly changing environments, given his versatile skills in planning, organizing, and developing human capital skills. Managing multi-skill tasks, which is characterized by multiple demands and deadlines within competing needs and priorities of organizations. Development and interpretations of policies, plans and legal frameworks into actionable work plans, coaching, mentoring, and imparting skills to a broad spectrum of practitioners, consulting services, gender and community development. Mr. Moses is well schooled. He possesses a Bachelor's of Arts in Social Sciences with Social Administration and Economics, and a Master of Arts of Social Sector Planning and Management. He has attended several health strengthening executive courses in the delivery of quality health services at Harvard University. HRH workforce staffing indicators at Killer University, United Kingdom, and International Health Systems Strengthening in Sweden. Thank you.
Mr. Arenaitwe Moses, on behalf of the Governing Council, the fellows, the members of the African Institute of Public Health Professionals, I do present to you this meritorious award of fellowship of the African Institute of Public Health Professionals because of your selfless contribution to healthcare development and safety of mankind in Uganda, in Africa, and in the world. Congratulations.
Sorry, please. We are having Dr. Bola Christy Achuloma. She's our mother in this institute. I will tell you the reason. She's our mother in this institute. The contribution Professor Achuloma has been rendering to this institute is enormous. Anytime, come up, ma. Anytime we have a problem, we consult Professor Achuloma. So it's our honor to have her in the institute. Of course, she's another big fish. You're welcome, ma'am. That's Professor Achuloma's wife.
Dr. Bola Christine Achuloma is a highly experienced professional in the field of academic libraries, with a focus on health information. She serves as the Polytechnic Librarian at Federal Polytechnic Ilaro, Ogun State, Nigeria. Dr. Achuloma boasts an extensive background with over 20 years of continuous work experience in academic libraries. Her educational qualifications include a Bachelor's of Arts in Modern European Language from Russia, 2 master's degrees, 1 in Library, Archival, and Information Studies from the University of Ibadan, and another in Personal Psychology from Olabisi Onabanjo University. Additionally, she holds a certificate and certificates in data processing and has completed several training courses. Doctor has achieved the pinnacle of academic achievement with a Doctor of Philosophy degree in Library, Archival and Information Studies from the University of Ibadan. She is actively involved in professional associations such as the Nigerian Library Association and the Society of Nigerian Archivists. Having previously served as the secretary for the Medical Librarian Association chapter and as the chairperson for the Association of Women Librarians, Osun State chapter. Notably, Dr. Atuloma is a member of the Association for Health Information and Libraries in Africa and the Medical Library Association of Nigeria. She has contributed to the field of publishing health information articles in peer-reviewed journals and contributed and participated in various national medical information issues. Her career path includes roles as the Assistant Chief University Librarian at the E.D. Basaja Balaba Memorial Library at Kampala International University, as well as service at the Medical Library of the University Western Campus in Ishaka, still in Uganda. She also held the position of University Librarian at Adeleke University, Ede, and Deputy University Librarian at Babcock University, Nigeria. Dr. Atuloma's professional competencies extend to information technology, software in packages, teaching at undergraduate and postgraduate levels, supervising students, budget planning and implementation, and the management of library collections, the database and IT network. She is very known for her highly intellectual ability, skills in leadership, and her ability to work well with colleagues. Thank you, Doctor.
Thank you very much. Yeah, then we are inviting Dr. Rukaya Ahmed. Ajia Rukaya Ahmed. You can see the reason being that we don't want anybody that, we don't want to be looking for ladder to decorate Dr. Atuloma. We have somebody that is tall, like her too. That's just on the light mode, on the lighter mood. Yes, sir. On behalf of the Governing Council, fellows and other members of African Public Health Professional, I present to you this meritorious award for your contribution to healthcare development and safety of mankind all over Nigeria, your country, Africa, and indeed all over the world. You're welcome, ma'am.
Thank you, sir.
Congratulations to Dr. Bola Christine Atuloma. Congratulations. Standing on the existing protocol, may I invite Dr. Mohammed Aminu. Dr. Mohammed Aminu obtained a bachelor's degree in medicine and surgery from the University of Maiduguri, and thereafter obtained a postgraduate diploma in general surgery from the University of Vienna Teaching Hospital, and later obtained a diploma in trauma surgery from University of Lübeck in Germany. Dr. Aminu had a working career as a surgeon for 25 years before venturing into healthcare administration, which he began with the appointment as a personal doctor to the governor of Borno State, which he served for 7 years, before he was appointed the medical director of Borno State Specialist Hospital in Maiduguri, Nigeria. He was later moved to the Ministry of Health as a Director of Emergency Medical Response and Humanitarian Services, which was created to coordinate the emergency responses to mitigate the challenges of the insurgency of Boko Haram in the state. This he did with his passion for 5 years, after which he was appointed the Chief Medical Director of Borno State Hospital Management Board, before his elevation to his current position as the Permanent Secretary of Health in Borno State Civil Service, Nigeria. Dr. Mohammed Aminu has contributed to the development and planning of several healthcare guidelines and policies in Borno State and the country at large, having contributed and participated in various committees, the commissions, and boards, both at the state and national level. Dr. Mohammed Aminu is a member of several bodies, both at national and international level. He is married with children. Congratulations, Doctor.
On behalf of the Council, the fellows and members of the African Institute of Public Health Professionals, I present this meritorious award to you, Mohamed Uluze, as a fellow of the African Institute of Public Health Professionals. Because of your contribution, selfless contribution towards healthcare development and safety of mankind in your state and country, in the ECOWAS community, on the African continent, and on the globe. Congratulations.
Congratulations again, Dr. Mohamed Aminu. Thank you. Standing on the existing protocol, you permit me to invite Professor Ahmed Adebowale Adedeji. Which one? Welcome, Professor. He is a professor of pharmacology, and he is the current chair in the Department of Pharmacology and Toxicology at the University of Rwanda. He is the coordinator of the Future of Medicine, Science and Technology and Innovation Group. This is a Pan-African multidisciplinary research initiative for universities across Africa. He obtained his bachelor's degree in biochemistry from Olabisi Onabano University, formerly called Ogun State University in Nigeria in 1992. Being very much interested in drugs and medical sciences and application in public health, he studied pharmacology at master's degree. He had his MPhil in pharmaceutical chemistry in 2004 and a doctorate in pharmacology in 2007, all at the University of Ibadan, Nigeria. He had his postdoctoral training with the World Health Organization Special Program in Tropical Diseases and Research in Geneva, Switzerland, as a career development fellow from the year 2008 to 2009. And he became a fellow of the African Technology of Policy Studies in Kenya and a fellow of the American Academy of Project Management in 2009 and 2010, respectively. Throughout his career, he has been hugely involved in academics, research and capacity building, and management in academic institutions. His training in Malaria Research Group in Ibadan under Professor Akin Soumi and Professor Ayode Oduala were uniquely transforming for his early research career. He started his academic career as a lecturer at that same year at the Olabisi Onabanjo University in Nigeria in 1997, where he worked until 2011. In the same year, he joined Kampala International University, Uganda, as an associate professor of pharmacology and assistant deputy vice chancellor. He was promoted to the rank of full professor of pharmacology in 2014. He then worked with Islamic University in Uganda, Catholic University in Rwanda, and University of Gitwe, ISPG, in Rwanda, where he was till 2019 before returning to Olabisi Onabanjo University, Nigeria. In between then, he founded Foresight Institute of Research and Translation, a private research institution aimed at transforming lives through research, training, and innovation, and served as the Pioneer Director General in 2018. Professor Adedeji, he pioneered complementary research programs that strengthens research in terms of capacity for undergraduate and postgraduate students in various disciplines. He initiated the first National Undergraduate Student Research Conference in Nigeria, held in November 2019 at Osun State, Nigeria University, as a way to promote engagement of youth in research for development and innovations and achieving of the SDG goals in Nigeria. Following his training with WHO, his interest deepens to contribute to research in terms of building in capacity and leadership development, especially in the young, vibrant African researchers, in such a way that the present and next generation of healthcare professionals and research scientists are able to leverage on the deliverables of the current efforts in the control and management of infectious neuropsychiatric diseases. He has supervised, mentored more than 60 undergraduate and postgraduate students from different African countries, inclusive myself. He has published over 65 peer-reviewed papers, and Professor has been a member of various international initiatives focused on building of capacity in African researchers. He is a member of DROS Africa, promoting use of Drosophila model for research of the continent. He works with other investigators on the neurobehavioral dimension of malaria diseases. He has contributed and participated in various international research and training activities. Congratulations, Professor.
Sorry, permit me to have been coming around anyway. Please, your attention. When we were looking for an indigenous organization in Rwanda here, you know, you can't just plan a conference without an organization on ground that understand the culture and the dynamics of the country you are coming from. A Nigerian introduced us to him. And I was so surprised that the person that introduced him has not even met him before. But what he said is that Prof is a good man. Even the person that read our citation to, when he was with me 3 days ago, the same comments. Prof is a good man. Please permit me to quote, if I don't quote, I think Julius Caesar. He said, or let me paraphrase. He said, he who that steals his wallet is not his own, it's not whatever, but he who robbed me of my good name has made me poor indeed. Prof, we are proud of you. We are proud of you. And because of his activity, while reading the citation, I now discover Firat. He introduced the wife to us, Ajia Kudirat Adedeji. Somebody I will call a one-woman majority Yes, please, Ajia, please, for recognition, please. A one-woman majority. Whatever achievement we are having here, to the glory of God, this person standing, God used her tremendously. I remember when she went to the ministry, like I just talked about socio-cultural, the dynamics of the country that we did not understand. I said, please, Ajia, leave the Ministry of Health out. She said one thing. She said, I don't believe, I don't give up. That I don't give up. Ajia, we are proud of you, and of course, this is the beginning of our relationship. Thank you very much. Yes, on behalf of the Governing Council, the fellow, the members of African Institute of Public Health Professional, I am presenting this meritorious award to you as a fellow of African Institute of Public Health Professional towards a selfless contribution to healthcare development and safety of mankind.
Let's welcome the wife, please. Don't put us under, please. Yeah, thank you, Professor. Congratulations again. Standing on the existing protocol, you permit me to invite Dr. Samira Ahmed Goko. Dr. Samira Ahmed Goko. Please clap for her. As she takes the stage, Doctor is currently a family doctor working with the Modibo Adamawa University Teaching Hospital, Yola, Nigeria. Her strong passion for finding lasting solutions to societal problems, while at the same time empowering individuals and building blocks of the society. Dr. Goko has had her elementary education in Borno State, Nigeria, and her secondary education in Adamawa and FCT, Abuja. In the attainment of her medical degree at University of Maiduguri, she began her clinical career at the famous and prestigious Ahmadu Bello University Teaching Hospital, Zaria. From there, Dr. Goko moved to World Health Organization to work on the field as a local government facilitator. It was while on this field assignment that she concluded on her plans to undergo a career in family medicine so as to address the societal inequalities and social determinants of health. Dr. Goko has vast knowledge and practice of public health from the classroom, consulting rooms, field, and the community levels. She has used her public health experience and practice to inform needed guidelines and policy practice in terms of research. She has and currently focused her research on areas of adolescent, gender, and geriatric care. This further underscores her passion for the weak and most vulnerable in the society at large. Her community service experience has known no bounds, and she is a member of several organizations, such as Society of the Family Physicians of Nigeria, Medical Women Association of Nigeria, Nigerian Medical Association, and several faith-based groups. Lest I forget. She is a medical entrepreneur par excellence, the CEO of so many farms, including Shama Pastries. Dr. Samira Ahmed Goko has actively participated at several African Institute of Public Health Professional events in Nigeria. She was also present at Cairo Conference in 2022, and now she's standing before us in Kigali in 2023. She is married and blessed with 4 lovely children, and at her leisure time, this seasoned clinician, wife and mother, likes reading and creating new recipes. Thank you, Doctor.
This person we are going to discuss later anyway. Yeah, we'll discuss later. Yeah. You're going out? Yeah, but I will come back. Okay, no problem. See the roots down. Okay, there was something before.
Congratulations, Doctor.
You can see as if we have taken our measurements. This is wonderful. Yes, on behalf of the Governing Council, members and fellow of African Institute of Public Health Professional, we present this award to you for your contribution to healthcare developments in your states, Adamawa, Nigeria, in your country, Nigeria, in Africa, and all over the world. Congratulations. Thank you very much. Please, picture, picture, picture. And I will invite the husband to come and take picture with her. Dr. Saidu. This is another gentleman. We know them in our institutes. Dr. Saidu. Thank you very much.
Congratulations, Doctor. Standing on the existing protocol, it is my pleasure to invite Dr. Oluwemi Nuruddin Olaleye.
Dr. Olufemi Nuruddin Olaleye. Dr. Olufemi Nuruddin Olaleye. Of course, you know the reason why I repeated that. Sorry, Dr. Oluremi Nuruddin Olaleye. At least we are from the same, we speak the same language. I should be able to pronounce the name better.
Doctor standing before you was born over 5 decades ago in Mushin, Lagos State, Nigeria. Doctor holds a Bachelor of Science degree as well as a Master's of Science degree in microbiology from the University of Lagos, and was awarded a Doctor of Philosophy degree at Lombarong University in United Kingdom. Dr. Nuruddin Olaleye joined the services of the Lagos State Polytechnic Ikorodu in November 1999 as a lecturer 2 and rose through the ranks to the position of chief lecturer in February 2017. He was appointed as rector of the Lagos State Polytechnic in December 2020. Dr. Oluremi midwifed the transmission of the Polytechnic to a University of Science and Technology, the first of its kind in Nigeria, having been appointed as the acting Vice Chancellor of Lagos State University of Science and Technology in 2022. He is a member of various professional bodies such as the Society of Applied Microbiology, United Kingdom, Informational Water Association, United Kingdom, Nigerian Institute of Food Science and Technology, Biotechnology Society of Nigeria, and Society of Research Association of Industrial Microbiologists of Nigeria, Foresight Network International, and African Association of Entrepreneurs. He is a fellow of international science, technology, education, arts, management, and social sciences. He is a fellow of Nigerian Institute of Training and Development, and he is a fellow of Institute of Islamic Finance Professionals. Dr. Nuruddin Oluremi Olaleye has served in his state in many ways. To mention but a few, he was a member of Lagos State Gubernatorial Advisory Committee from 2011 to 2015. He was a member of Lagos State Participatory Project on Voted Education in November 2010. He was a member of Lagos State Electoral Reforms Committee from 2007 to 2010. Dr. Oluremi Nuruddin Olaleye had facilitated trainings with the UNICEF on water safety and hygiene, known as WASH, in different states of Nigeria, such as Osun and Cross River states. He had made presentation on WASH in Kenya, Uganda, Germany, United States, United Kingdom, Turkey, to mention but a few. Dr. Nuruddin is a teacher. He is an author. He is the founder of Sub-Saharan Center of Environment and Water Research Innovations and Development. He is a shrewd and resourceful academician with over 50 publications and journals to his credit. Dr. Nuruddin Oluremi Olaleye is a world-acclaimed water safety expert with many years of experience in academic, research, and community work, and also the mentoring of youth. Dr. Olaleye is a recipient of over 50 awards from the professional, social community, religious, and academic sectors of the society. Dr. Nuruddin Oluremi Olaleye is happily married with children. Congratulations, Doctor.
On behalf of the Governing Council, fellows, and members of African Institute of Public Health Professional, I present this award to you for your contribution to healthcare development. The world, all over your country, Africa, all over Nigeria, your country, Africa, your continent, and indeed all over the world. Congratulations. If you are just been inducted, just wait behind. You need to take our oaths. And if you have been inducted before this time, you can just go and have your seats. Thank you, Ajia. This is another smiling mother in the institute, Ajia Rukayat Hamed. We have good people in this our institute. Ajia, you're welcome. No, it's just a...
You will take over from here.
Please, I need a wonderful picture, smart one. This picture will be going on our website, please. A very good picture. You are going to read after me. Therefore, as a member, hi, your name. Pledge to conduct myself professionally with truth, accuracy, fairness, and responsibility to the public, to foster the highest standard of professional competence among those whom I am responsible, to enhance the proficiency, stature of the profession by acquiring and applying knowledge in the most appropriate manner, to participate in all professional development programs, so that one's knowledge and performance are enhanced, to dissociate myself from anything that will tarnish the good image of the institute or bring the institute into disrepute, to honor the confidence received or given in the course of my professional activity, to comply with the letter and the intent of the laws of the country in which I practice and agree contractual obligations, to cooperate with all organizations and individuals engaged in activities which promote the development and the standing of the institute, to have positive duty at all times, to respect the truth and shall not disseminate false or misleading information, to abide by and to encourage others to practice the professional code of ethics of the Institute. That I made this pledge in good faith and in accordance with the policy of the Institute. So help me God. You are going to sign dates and return to us. Please listen to this important information. After your name, to show that you are a fellow of our institute, F for fellow, I for institute, P, public, H, no, we don't use the last F. Fellow African Institute of Public Health. We don't put the last P. FAIPH. Please picture, I need picture. Congratulations, and please you can congratulate yourself. And I will look forward to seeing you. I just want to let the cat out of the bag, but I can understand that some people are traveling. They are traveling back. Let me say, see you in Accra next year. We come in the same way we came. Thank you very much. You are all welcome. You are writing your name up. Your name up, please. Your name up, then sign date. Okay, your certificate, please.
Congratulations.
What would I do without your smart mouth?
Congratulations. Please, we can clap for them as they take their seats. Congratulations once again. Thank you, Prof. Thank you, Doctor. Thank you, Doctor. Thank you. This is the day the Lord has made. Congratulations. Thank you. Thank you. The music is dedicated to all of you. Thank you. Congratulations. Thank you, Doctor. Thank you. Thank you. Thank you, our amiable registrar. Thank you. Thank you, our secretary, Betty. Thank you so much. The song is dedicated to our newly inducted fellows of the African Institute of Public Health. Thank you. DJ, keep on playing. Thank you. Thank you. Thank you. Thank you. Thank you. I like the smiles on the professors' faces. Thank you. Don't forget your certificate, please. Thank you. Please come forward for your certificate. Please come forward for your certificate. I call them. All the newly inducted fellows, please come forward for your certificate. Professor Adedeji. Professor Adedeji, please come forward for your certificate. Dr. Oluremi, please, your certificate. Professor Gaba, please come forward for your certificate. Dr. Aminu Moses Arinetwe, please come forward for your certificates. Chukwu Zoba Obina Anthony, Dr. Adamu Danladi, Mrs. Fehintola Olayinka Ajitun Mobi, come for your certificate. Mrs. Fokukua Tiopista. Okay. Dr. Bola Christy Atuloma, please come forward for your certificate.
In the way now, I guess that I'll begin to the end. Guess I'm on my way. I might be glad to stay.
Yes, meet Betty. All newly inducted fellows, please meet Betty for your certificate. Congratulations once again to the newly inducted fellows. Congratulations. Congratulations. As we take the picture and the background music plays, you permit me to invite the Managing Director of Foresight to tell us where we can have our lunch from. Thank you, Managing Director.
Thank you, Dr. Kevin. Hello? Please, can you hear me? Our lunch is over delayed, not a bit delayed now. We are sorry about that. For the fellow members of the Institute, we are taking our lunch from the main restaurant, that is Agashiro, down there. So all the fellow members, please move down to the restaurant for your lunch.
The Managing Director has said our lunch is ready.
So for others, we have 2 other areas left. There is a place here upstairs here, and that's so ensure you get your meal ticket from the entrance as you are moving out. Thank you.
Thank you. Make sure you get your meal ticket from the Managing Director, as she will give us more instructions. Yeah, good afternoon, members. Welcome back from the lunch. Please, can we have our seats? Members that are outside, can you You come inside, please. We are scheduled to start in 1 minute for the last section of the day. Members outside, please, you come inside and have your seat.
Good afternoon. I stand on existing protocol. It's probably the best time to present is after lunch, when you have postprandial diversion of blood from the brain and everybody will be dozing off. It's the minister, the Minister of Health of Rwanda in absentia, the Honorable Commissioner, African Union Commissioner for Health and Human Services, is building resilient health systems and team strengthening. It is my singular honor and privilege. I'm truly honored to stand before you today at this institution of African public health professionals on the 5th annual international conference here in Kigali, Rwanda. The theme, I can see that this theme and sub-themes were carefully chosen to emphasize the health sector's priorities within context of Africa, B, to demonstrate a rapid reflection on our journey to solving the challenges, taking into account the practical aspects in our continent, C, to reinforce overarching objectives of establishing country health systems that guarantees universal access to essential health services, which normally would cover prevention, promotion, treatment, rehabilitation of well-being, but a fundamental human right. It is a measure of our commitment to equity, justice, and the dignity of every individual. Achieving universal health coverage is not a choice, it is an obligation, a promise to provide quality health care to all, regardless of their socio-economic status. It is the embodiment of the continent's vision, advantage for us as individual nations. Though some great progress has been made over the years, the pace has not been commensurate with the investments, even as inadequate as they are, and the complexities of health systems have only added to drag in the movement towards achievement of our collective universal health care goals. As alluded to today by our erstwhile Professor Adetula, he has enumerated the historical background today, this morning in his lecture, and I would want to emphasize that before health, the collective efforts we make today will undoubtedly shape the future of healthcare in our continent. Health systems resilience is about A, being prepared to manage unexpected challenges when they happen. This is crucial. And being able to adapt to reduce the damage from such shocks when such things happen, and also how fast you recover when these incidents take place, and also to recognize any lessons as a result of such shocks to this system, and consider the improvement of performances and safety of the system. And in no continent, this is more so urgently needed than in the African continent of today. As we have seen, the challenges can be multifaceted, from infectious diseases to non-communicable diseases, the latter, some of which are linked to lifestyles, and therefore, if we continue in this trajectory, as enumerated earlier on today, then the continent will be doomed. Because the population, for example, of Nigeria, by the year 2050, will be 400 million. 400 million means Nigeria will be the third largest country in the world, after India and China. And the continent of Africa, which has now 1.22 billion, you can imagine what it will be in the year 2050. So health systems must take into cognizance these facts and work towards salvaging the system and organizing ourselves to be able to leave a legacy to our grandchildren or great-grandchildren who may be alive then. So health systems resilience is about being prepared to manage unexpected challenges, as I said. So some of the reasons are that one of the pillars supporting resilient health system is the strength of the team. In healthcare, success is a collective effort, as all the people who spoke today have clearly demonstrated and pointed out about importance of collectivism in tackling health problems. Today, we will explore the strategies and best practices for team strengthening. This encompasses the fostering effective communication, promoting interdisciplinary collaboration, and investing in the professional development of our health workforce. This is very crucial that we bear that in mind. Why Africa needs building resilient health system and team strengthening, one might ask. Africa, as the second most populous continent in the world, is facing formidable challenges in the quest to ensure that health and well-being of its diverse population of approximately 1.22 billion people, which constitutes 15.3% of the global population. There is urgent need for building a resilient health systems and team strengthening in Africa, delving into the profound impact of prevalent health issues and the vulnerabilities exposed, particularly by the COVID-19 pandemic. It is crucial to address these challenges comprehensively, considering the socio-economic, the political, and the geographical complexities unique to the continent that is still afflicted by lingering negative effects of colonization, as enumerated this morning, how we started before the colonization and what colonization did, and post-colonization we're still struggling in getting our act together. The health landscape in Africa is marked by stark contrast between population size and the burden of disease. While the continent is home to a substantial portion of the world's population, the health statistics reveal a concerning reality. 5 African countries, namely Democratic Republic of Congo, Ethiopia, Nigeria, South Africa, and the United Republic of Tanzania, collectively account for nearly 50% of the total years lost in healthy life, as measured by the disability-adjusted life years. These alarming statistics underscores the urgent need for targeted interventions in the continent. In 2015, approximately 630 million years of healthy life were lost across Africa due to various diseases, including a staggering economic loss exceeding $2.4 trillion international dollars annually. These numbers highlight the profound impact of health challenges on both the individual and the broader economic context, emphasizing the interconnectedness of health and overall societal well-being. Historically, Africa has grappled with infectious diseases outbreaks, with countries like Guinea, Liberia, Nigeria, and Sierra Leone facing the devastating Ebola epidemic from 2014 to 2016. However, the paradigm shift has occurred, as I said earlier on, of non-communicable diseases, which have now emerged as the predominant contributors to disease burden, constituting 37% of the total. And also, these non-communicable diseases are very expensive, as have been alluded to earlier on today, because prevention is better and cheaper than cure. So we must do everything to reduce these non-communicable diseases, because the MRIs of this world, the CT scans of this world, and in some places using robots in treating certain diseases, including prostate cancer, is very expensive. And therefore, we should do everything possible to prevent them. The global COVID-19 pandemic has laid bare the vulnerabilities of health systems worldwide, with Africa facing unique challenges due to the historical weak healthcare systems. The continent lacks comprehensive, context-informed, and homegrown 12-pillar clinical governance program covering critical areas such as political will, the leadership, standards of care, financing, facility readiness, and assured supply of essential equipment, medicines, and commodities. I'm glad one of the participants have mentioned this earlier on this morning when discussion was taking place. The pandemic also exposed inadequacies in African systems, revealing gaps in laboratories testing, in therapeutics, in ventilators, in isolation facilities, contact tracing, and treatment of severe cases. Furthermore, the shortage of skilled and more motivated human resources for health, coupled with absence of supportive supervision, mentoring, clinical audit and research, monitoring and evaluation, has intensified the negative impact of the pandemic. Even though African population is 15%, but research in Africa is only about 2%, Africa supporting the rest of the world. So we need to change. Implementing basic infection prevention in Africa, as during the COVID-19, showed pandemic became an uphill task or battle in Africa due to the lack of potable water supply. And I'm glad this was also highlighted this morning about the importance of water, which one needs for frequent hand washing during COVID, and also now in some parts of Nigeria, we have diphtheria. There's inadequate waste management in most of our systems, and rampant illiteracy, poverty, and widespread ignorance created an environment where preventative measures were difficult to enforce effectively. The lockdowns and social distancing strategies commonly employed to mitigate spread of COVID-19 virus proved to be more detrimental in the African context in view of the prevailing socio-economic challenges. A lot of Africans were not storing food at home. They go out to the market on a daily basis, and that became a big problem during the COVID-19. Weak and poorly resourced primary healthcare systems, particularly in rural communities, which we knew today how it was handed down in Nigeria, where a significant portion of our population in Africa reside and work, exacerbate the impact of health shocks like the COVID-19. The lack of accessible and quality healthcare services in these areas not only hampers the response to acute health crises, but also perpetuates long-term health disparities, contributing to overall vulnerability of the population. Now, looking at the key components of building a resilient health system, first of all is adaptive leadership, which was mentioned today. The ability to navigate uncertainty and lead teams through dynamic challenges is very essential. Adaptive leadership empowers individuals at all levels of the healthcare hierarchy to contribute to problem solving and innovation. 2, strategic planning and preparedness. Anticipating and preparing for potential threats is really fundamental. Importance of strategic planning, scenario analysis, and prepared exercises in building a resilient health system cannot be overemphasized here. The issue of technological integration was mentioned today, and therefore we should embrace technological advancements which can significantly enhance healthcare delivery, from telemedicine, which was mentioned today, to data analytics, to to drones. We will have to explore how technology can be catalyst for resilience in Africa's health systems. Interconnected and decentralized infrastructure is important. Resilient health systems require interconnectedness and decentralization of the infrastructure. This involves creating networks that can quickly adapt and distribute resources based on the evolving needs of different regions or communities. Decentralization ensures that the burden of decision-making and resource allocation is not solely concentrated at the top, but it is distributed across various levels of healthcare system. Robust data management systems, making it efficient and secure, is crucial for informed decision-making and resource allocation. Even in Nigeria, some institutions are still not fully computerized, and therefore data collection is an uphill task. This has to change. A resilient health system must have robust data collection, storage, and analysis capabilities to track and respond to health trends, emergencies, and emerging threats promptly. Community engagement, which has been mentioned today, is important because building resilience involves active participation and empowerment of the communities. This has been hammered home today, and I'm re-emphasizing it. Engaging communities in healthcare decision-making, especially health promotion and disaster preparedness, not only strengthens the bond between the healthcare providers and the public, but also ensures that interventions are culturally sensitive and contextually relevant. Continuous learning and improvement is important in resilient health systems. Fostering a culture of a continuous learning and improvement, regular assessments, feedback loops, and post-event analysis contribute to an adaptive healthcare environment. Robust logistics and supply chain management is crucial, as the system requires flexible supply chain management. This involves an adequate stockpile of essential medical supplies, developing alternative sourcing strategies, and establishing efficient distribution channels to ensure the timely availability of resources during emergencies. Certainly in Nigeria, drugs and medical supply consumables are being, agencies are being created. And I know here there are in Kano, in Jigawa, and Yobe, and many other states. And we're now developing one in Borno State, where with a PPP arrangement with drug manufacturers, we can source them at very good pricing, and a robust supply chain is being established, and therefore reduce the out-of-stock syndrome, and we will be purchasing from sure sources. Effective communication is important and is vital during health crisis. Developing communication strategies that convey accurate information is timely, in a timely manner, to both healthcare professionals and the public, fosters trust and minimizes misinformation, and ensures a coordinated response to health challenges. International collaboration and coordination is also essential, and it transcends beyond national borders, making international collaboration crucial. As we have witnessed in my state, Borno State, where we've suffered from insurgency for 13 years, and we were in emergency period, we are now in recovery phase, and we have collaborated with a lot of partners, ranging from WHO to Bill and Melinda Gates to Dangote Foundation, etc., to helping and strengthen our systems. Legal and policy frameworks is important, as policy frameworks is essential for effective health system resilience. Because, for example, the Drugs and Medical Supply Agency had to be created by law. We have state assemblies, so it had to go to them to deliberate on it, and then the governor assented to it as a law in the state, as an example. So actions that we can take to build resilient health systems and team strengthening for Africa would include the implementation of integrated approaches aimed at enhancing the resilience of health system in Africa, which involves comprehensive strategy encompassing the entire health system, including focusing specifically on primary health care, which has been hammered home today. Primary health care, which started in 1978, is really the gatekeeper, and we must adopt it wholeheartedly, putting the people who have got the love for primary health care as managers, not people who just want to be there because of the available resources. For instance, the homegrown 12-pillar clinical governance program emphasized the importance of protection of patients and support for practitioners, all in tandem. It is a noteworthy initiative, worthy of scale across the continent, as this clinical governance and the PAC, which is Practical Access to Care Kit, has now been adopted by the World Health Organization. And very soon, the minister has shown great interest. We will roll it out across Nigeria. The realization of universal health coverage and health security within the current decade in Africa hangs on the establishment of resilient health systems. This involves harmonious integration of local contextual innovations and proactive measures to support the dynamic healthcare landscape. A resilient health system in Africa is one that not only garners the trust of the communities, but also well-prepared, well-resourced, and flexible. It should be capable of absorbing the impact of disruptive events, ensuring the continuity of safe health services. Central to the concept of resilience is the presence of multi-compensated, well-trained, and well-supplied health workforce. Investing in human resources for health is integral to the overall resilience of healthcare systems. And talking about health resources for health, unfortunately, the African health workforce are being targeted by so-called greener pastures, including the Middle East, like Saudi Arabia, and the UK, the USA, as part of, in the Nigerian context, we refer to as JAPA syndrome, or brain drain. So we have to take actions to overcome these big problems of brain drain affecting the workforce in our health care systems in Africa. Central to the concept of resilience, it's so important for us to key into several components on practical and on the political will. A strategic increase in domestic investment dedicated to health systems and all hazards emergency risk management is crucial. Example is in Borno State, our governor, Professor Babagana Omar Azlam, has recently given the go-ahead for all the staff who are working in rural areas a 30% increment in their salary. This, no doubt, will attract a lot of our staff to be able to stay and offer their services, and sometimes ignore all the poachings from the greener pastures. So the establishment institutionalized mechanisms for promoting whole of society awareness regarding health and well-being is imperative. We have also in Borno State, because of the insurgency, beefing up on human resources for health, we are setting up 2 schools of nursing and midwifery, one in Goza and the other one in Monguno in the north and Goza in the south, in addition to our College of Nursing, which the numbers have now been upscaled to 400 per year compared to the previous one of 100. And also we are building a State University Teaching Hospital, and already medical students, dentists, midwives, nurses, etc. Have started applying to commence their education this year. This is to increase our workforce in the near and foreseeable future. So building resilience and inclusiveness healthcare systems for healthy Africa, different countries in Africa have aimed to explore some key components crucial for the development of robust healthcare infrastructure. Here, I will be sharing innovative ideas, evidence-based practices, and collaborative efforts that will contribute to the realization of healthier and more resilient Africa. Building a skilled and motivated workforce, as alluded to earlier, is important in Africa. A fundamental aspect is the development of skilled and motivated health care workforce. It's often said that cornerstone of any resilient health care system is skilled and motivated workforce. Strategies and initiatives to cultivate a proficient and dedicated healthcare team are as follows. Capacity building programs We need to expand our scope of implementing comprehensive training programs to enhance the skills of healthcare professionals, ensuring they are well equipped to address the evolving health challenges, including diseases, outbreaks, and other global pandemics. Capacity building, we have recently done the training on clinical governance and also the practical access to care kit in Borno State, and now is going to be cascaded to all the primary healthcare institutions as we did train the trainers. And this is something that the WHO has already adopted, and therefore is very crucial for us, to implement it, especially we're reeling on the fact that we have had insurgency for the last 13 years. But nevertheless, I want to share this good news with you that the Challenge Fund this year, in May 2023, Borno State emerged as the best in primary healthcare services in the whole of Nigeria. We had Golden Handshake from Bill and Melinda Gates Foundation and Dangote Foundation and other partners of $1.2 million. So we are already preparing that next year's challenge in May will still come to Borno State. So professional development is key, and therefore we need to establish continuous learning opportunities, mentorship programs, and career progressions pathways to keep healthcare workers motivated and engaged in their roles across all the tiers of the healthcare system. Emphasis on mental health is urgent, and we must recognize and address mental health needs of healthcare workers, the population, fostering a supportive environment to prevent burnout and enhance overall well-being. The PAC system has got a very large area on mental health, and therefore our primary healthcare institutions will be using the manual for the PAC, which can help them greatly as to when to refer and when they can treat. And this can be used by both the medical doctor, if there is one, the nurses, the midwives, the CHU, the JCHU, etc. So it's something that is, can be done by all. And I suggest you have a look at this PAC system in your primary healthcare systems. But wait until after the next year's challenge is finished, then we can, then we can give you the secrets. The harnessing of evidence-based research and development for better health is very important, which can bring about a strong foundation in evidence-based practice. I will talk about the role of research and development in shaping a healthier Africa. As alluded to today, only 2% of research is coming out of Africa, whose population is 15%. We have to encourage a culture of research within healthcare institutions, fostering an environment that values and supports research. Huge investments need to be channeled into research, and both locally and internationally. We must collaborate with academia, as we have seen today, Professor Nuruddin and others. This cannot be overemphasized in terms of collaboration. It aims to foster partnerships between healthcare organizations and academic institutions to promote collaborative research projects that contribute to innovative healthcare solutions. The implementation of best practice is important. Based on the findings from the research, this is translated into actionable policies and practices, ensuring that healthcare systems are continuously informed and updated with the latest evidence-based approaches suitable to the continent. Strengthening healthcare access and institutional governance is a panacea for attainment of universal health coverage. The universal health coverage is pivotal goal for resilient health systems. It remains paramount goal for healthcare systems worldwide. Key strategies to strengthen healthcare access and institutional governance towards achieving universal healthcare coverage includes community-centered approach, which we have discussed this morning, and I've talked about it earlier on. We need to prioritize community engagement in healthcare decision-making process, ensuring that services are accessible and culturally relevant. For example, in our primary healthcare system, we have meetings with ward heads, which they attend, with district heads, which they attend, with traditional rulers, which emirs, which will they attend, commissioner will attend, deputy governor will attend, and governor must attend. So therefore, it's a cascade, and in that way that the message really goes down, and primary healthcare is truly then becomes embedded in our system. And currently, His Excellency, the Governor, is building so many primary healthcare systems, as we've lost 45% of our health institutions during the insurgency, but we are now virtually reached one primary healthcare per ward, as it is of now in Borno State. The effective governance structures, continuous advocacy for transparent and accountable governance structures within healthcare institutions, fostering trust and confidence in the healthcare is essential. Technology we've alluded to earlier on, so we have to explore and the integration of technology to enhance healthcare accessibility, such as telemedicine and mobile health clinics, especially in remote areas, which at the moment is going on here in Rwanda. We have to look at also the issue of innovative financing of the 21st healthcare agenda. Financing healthcare in 21st century requires innovative approaches to address the growing demands on healthcare systems. Certainly, we do not rely on the budget that comes from the state. We partner with a lot of organizations. Some have been building or constructing primary health cares for us and equipping them, as well as solarizing them or putting solars, especially sustainable energy, where there is no national grid, to whom we are very grateful for that. We have to look into public-private partnerships, and this collaboration between public and private sectors will leverage on resources and expertise for healthcare infrastructure development and service delivery. We have to also look at health insurance innovations. I'm pleased to say Borno has got a health insurance in place. We call it contributory agencies, and I believe many states in Nigeria have the same. But we have already seen the benefits of both the formal and informal registration as it impacts on their health. African countries need to encourage investments with a dual focus on financial returns and positive social impact, attracting funding for healthcare initiatives from socially responsible investors within and across the continent of Africa. Digital transformation and health information systems. In this era of rapid technological advancement, the digital transformation of healthcare is inevitable. For example, we are upgrading our medical warehouse to pharma grade, and we are digitalizing the systems, so much so that we will have CCTV, we will have a dashboard even in my office where I can check on what's going on in the warehouse, which drugs are being moved, so that this will reduce filtrage and also other things that may go on without such security efforts being put into place. So we need to buy into technology to help us with this. And technology would also include electronic health records, which some states in Nigeria have adopted, and we are also looking into it quite seriously. Telehealth and remote monitoring is already reached Nigeria, and I believe some states are also buying into it, and we are also looking into it. Cyber security measures, we need to protect sensitive health data and maintain the integrity of digital health systems. So therefore, you must put into place cyber security measures in place. Otherwise, our system can be vulnerable. So as I conclude, my respected fellows and ladies and gentlemen, I want to thank you once again, our host, African Institute of Public Health Professionals, and the good people of Kigali, whose effort have contributed immensely to the success of this conference. I also extend my gratitude to every speaker at this conference so far. I urge us all to keep the vision of ensuring and sustaining an improved healthcare system in our dear continent. The path to healthier and more resilient communities in Africa requires our collective commitment to building strong, adaptable health systems and fostering empowered collaborative teams. As we engage in discussions over the next few days, let us remember that our actions and insights here have the potential to transform the landscape of public health in our continent. The need for building resilient health systems and team strengthening in Africa is more critical than ever before. The continent's unique challenges, ranging from infectious diseases outbreaks, to growing burden of non-communicable diseases, underscore this necessity for comprehensive and context-specific approach. Addressing these challenges requires a multifaceted, context-specific approach. Addressing this will encompass political will, leadership, healthcare infrastructure development, training, and motivation of healthcare professionals, and the community engagement. Only through such holistic efforts can Africa hope to bridge the existing gaps in health systems, ensuring a healthier and more resilient future for its diverse population. Let us in Africa recognize health boards and professionals who will continue the long path towards the Sustainable Development Goals, a promise of a just, equitable, and sustainable health system, our common heritage, a promise of peace and prosperity for Africa, where no one is left behind. Thank you for your attention, and I look forward to our shared journey towards a healthier and more resilient Africa. Thank you.
Thank you, Professor.
Thank you.
Thank you. Thank you. As Professor has his seat, you permit me to invite the moderator of the panel, no other person than Associate Professor Simeon Olubiyi He works for the University of Ilorin, Department of Nursing, Ilorin, Nigeria. Associate Professor, please, you're welcome.
Please, I just want to ask and plead that you allow me also, not just to leverage on the existing protocol, but to sit there. Please, as public practitioner, can we please rise just for 1 minute? You've been sitting down, some of you are dozing. Please, can you just stretch? Some of you are not doing it. I can see you from here. But you are pardoned because they said the protocol must not be broken. Please sit down. Thank you very much. It's my pleasure to be asked to do this, and I don't take it for granted. I take it with a high sense of responsibility. I don't know how many minutes we have for this. MC. He said 15, 20. How can we do justice to this 15, 20 work? Please, if you are a teacher seated here, please can I see your hands up? A teacher, educationist. Thank you very much. Please, I hope the registrar is taking note. If you are a health practitioner, medical doctor, you are a nurse, you are a pharmacist, can we see your hands up? Good. If you're an engineer, can we see your hands up? A farmer. Okay. I'm not saying that farming as secondary. I'm saying farming. Okay. If you're a politician, can we see your hands up? Politician. I know you, sir. The way I saw you seated in the plane, I know you are one. I expect to see that the speaker who have just spoken will raise up his hand, but I know that whether you raise up your hand, you are a politician. Please, let's celebrate again This discussion is 15 minutes, but MC, you are the one to tell us when to stop, because we can't finish the discussion. Let me commend the registrar. This is the only institute that I will see has people of diverse professions. I am a nurse. Nursing is my constituency, but public health is my specialty. But even among nurses, I don't think we have this type of synergy. So please, again, let's appreciate ourselves. We have heard so much from the last speaker, and it couldn't have been better than that. In fact, sir, permit me to ask that you help us tell your governor, no, let's tell the president of the country, if possible, let's allow your governor to go through all the states and spend one year. Honestly, please let your governor know that somebody is asking him that after this tenure, he can go to Kwara State and contest. From Kwara State, let him go to Edo State. This man deserves standing ovation, the governor of that state. Please help me celebrate that governor. Thank you. That governor is going places. He's going places. I'm looking forward to meeting him one day. Please, Commissioner, are you hearing? I want to meet him one day. Please, the following people will be coming up to discuss. First on the list is no other person than Dr. Ayodele Bankole, the registrar of the institute. Please, as he's coming, let's bring him up. Next is Dr. Samsudeen Suleiman Yahaya, the ES, Katsina State Primary Health Care Development Agency. We also have Dr. Iniabasi, U.S. President's Malaria Initiative for States Projects. And then we have Chukwuemezi Okolo from Right Place Health, Texas, USA. Wow. Please, let's celebrate all of them. Hey. My job is, please, I hope somebody is taking notes. After this discussion, after this conference, something must be driving us somewhere. We can't be here for 2-3 days, and when we are done, we just shake hands and then go. Something must be discussed about this conference when next we meet in Ghana. We must ask ourselves, what have we achieved? We are to answer to discuss some of the issues raised by our distinguished, professor. In fact, that lecture passed for inaugural lecture. And I think we need to celebrate you again, sir, for digging deep. A lot have been discussed, and it's all about building resilient health systems and team strengthening. I'll start my first question. Please, I hope you make a microphone available to him. MC, where are you? Or you have taken sabbatical because somebody is standing up? Okay. Okay, thank you. Thank you very much. Building resilient health system is everybody's job. Thank you. Okay. Please let nobody sleep. Oh, if you, I specialize in ophthalmic nursing, so I can see everybody here. Is that you are seeing me or you are not seeing me, but I'm seeing you. So please let everybody be sharp and active. First question is onto the registrar. You have heard it, and you are still hearing it, and you still be hearing it. To ensure that we build a resilient health systems and team strengthening, what is the place of budgetary allocation to health sector in Africa?
Yes, thank you very much. Please permit me to stand up. I couldn't stand where you said we should stretch our body. And just like you said something very fundamental. If we continue discussing this topic, we may not live here today. And I actually want to appreciate Professor Babagana for that wonderful discussion. If we look at the budgetary allocation to health system in Africa, especially the sub-Saharan African countries, we are not yet there. And of course, our leaders, they are being cosmetic in their approach to health system in Africa. Like I said, in sub-Saharan African country. A country that is budgeting 2%, 3%, 4% to health system is not ready. The recommendation of WHO in Abuja Declaration was 15%. 15%. 2% is far. 4% is far. Unfortunately, again, our leaders, like Professor Atuluma, discussed with us on inequality. You see that serious inequality in the system because our leaders are not part of the healthcare system. Our healthcare system will be good, or is good, when our presidents, and indeed their cabinet member, their first subscriber to eat. Our health system is good when our president and our cabinet and his cabinet member, or their cabinet member rather, let me generalize it, they are first enrollee rather to our national health insurance scheme. A system whereby when the leaders are sick, they are flown abroad. Let me round up by giving an example of a businessman that went into business of airline. He decided to go and buy refurbished aircraft in the US. After buying it, he went for some shopping. All the items he purchased or he bought, he dropped them in the aircraft and told the pilots, "We meet in Africa." Because he himself was not sure if the aircraft we get to the country, we get to Africa. Our leaders, they are paying lip service to healthcare system in Africa, and I want to use this opportunity to call our leaders in Africa to upscale, our politicians to upscale budgetary allocation to health sector, because without that, we cannot have a robust and resilient healthcare system. Thank you very much.
Please, let's clap for him. Let's appreciate him. Thank you very much. The next question is to Dr. Samsudeen. And of course, glad enough that you are the ES of your state's primary healthcare development agency. What's the place of the training of health workers as part of the approach to building a healthier and resilient communities in Africa? We have states. When it comes to the issue of immunization, anybody could just be picked to go and do it. All we're after is getting the data. But we know this is not going to help us. It's not helping us. Sir, what do you think this point can serve as a force to helping us achieve this? The training of health professionals. Thank you, sir.
Thank you very much to the speaker and the moderator of this discussion. If you look at the building blocks of health system, we have the leadership and governance. We have healthcare financing, which the issue of budgetary allocation is related to. We have human resource for health management information system, vaccine products, service delivery. So all these things. So human resource, when you don't have human resource that have the capacity, the competence, the ability to, discharge and provide this service delivery. So ultimately, you are going to have a very weak system that cannot be said to be resilient. Looking at the COVID-19 pandemic, we have seen how systems, the so-called developed nations, the system crumbled because simply, they were not prepared. Human resource for health is central in making sure that we tackle every challenge, every insecurity that affects, that comes with any public health threat. When you train healthcare providers, for example, now we know every time we have these emerging and reimagine threats, like the one I've just mentioned, the COVID, the monkeypox, we have had resurgence of diphtheria, and so many other, disease of public health importance. We have introduced new vaccines recently. Rotavirus vaccine was introduced just early this year. Now we are talking of HPV vaccine, so many other innovations coming up. Without proper training of healthcare workforce, you will not be able to address these key challenges. One of the issues I know for a lot of doctors and nurses that are living in droves out of Nigeria and many countries in Africa, it's not just about salaries or wages, it's about providing the enabling environment, which training is central to that. If you are not given the right opportunity, the right enabling environment, the right training, skills and equipment to work with, job satisfaction is very important. So training is very, very important, and looking at the dynamics of healthcare delivery system, the importance of training cannot be overemphasized. For us let me come down to what we are doing in Katsina State. You've made mention of anytime we do any form of campaign, be it supplemental immunization campaign or we do the routine one, training is part and parcel of that. And we have training funds that we give as part of statutory deduction from every LGE, and is pooled to the State Primary Healthcare Agency, and we have our training plans. At the beginning of the year, we look at where are the training gaps and who need to be trained. So based on that, just to underscore the importance we put to training of healthcare workers, that is the only way to keep up and to ensure that you have a resilient health system that is ready to tackle any potential threat that can affect our nations. So in summary, training is very, very critical and is part of, without training and retraining, when we say training, it doesn't have to be the didactic, it can be on-the-job training, mentoring, and so many other forms of training. That is the only way to ensure that we improve on service delivery, to ensure that we tackle and reduce the burden of diseases as they come. Thank you.
Thank you very much. Please, let's give him a round of applause. Knowing that it's not all about the workforce within the health sector, this question is to Dr. Niabasi. Intersectoral collaboration. How far can it be of assistance in building a healthier resident communities? Some of our community, the road network is not good. In some places, don't even have the facilities for storage. So, but what is the place of intersectoral collaboration? Thank you.
Thank you very much. I want to commend the Honorable Commissioner because I worked in Borno State for 4 years. I left Borno State last year, and I can attest to what he's saying. Coming out from insurgency to a point that your state can come tops out of 36 plus one state in a country is not an easy thing. How can we collaborate? Because the multi-sectoral collaboration is key. The health sector cannot do it all alone. Health sector cannot do it all alone. When we talk of waste management, the health sector cannot do it alone. We need the environmental sector. We need social sector. For instance, when we talk of psychosocial support, to have a resilient health system, we need people to be psychosocially stable, and we need the social sector to be part of it. We have a lot of gender cases all over, which at the end of the day, the survivors need to be attended to in the health sector. As such, we need all the sectors that can work together to ensure that we have the needed services provided. What are the other sectors that we can collaborate with apart from the routine health? Education sector. We discovered that if we say only health, the schools that turns out medical personnel are not health school, they are not health sector to say. They are educational sector. So we need to collaborate with them such that from the inception of their training, the basic things that needs to be taught are taught. You'll be shocked that you find people coming out from medical school, nursing school, pharmacy school, even school of health tech, and they don't even know what the disposable syringes look like. And these people come out to be those that are implementing or administering vaccines to people. They are done in school and they are just meeting the things that they are going to implement out there. So we need to collaborate with them from the inception. When we go to the malaria sector, I am a malariologist. You find people that are out from school today and they don't know what a rapid diagnostic test kit is. Yet these are the tools that we expect them to work with. And you are coming to train them on the job. You need to have these things incorporated into their curriculum in school. So the health sector needs to collaborate with a lot of sectors, educational sector, even housing. When we talk of tuberculosis, what is the easiest way of spread of tuberculosis? Is crowding, poor housing. So we need to collaborate with the housing sector. What of finance? No matter what we do, if there is no financial support, we cannot move an inch. We are praising a Borno State governor now because he made sure that all the sectors that I've mentioned here, because I worked with them, work together. In fact, I also want to mention, sir, you weren't there. It was in Borno State that we had the first, what we call ATM sector, AIDS, tuberculosis, and malaria, where we tried to come together, come up with a work plan. Professor Dr. Gluse can attest to this. Come up with a work plan under the humanitarian sector to see if we say we are going out for HIV outreach. Can we at that outreach also provide services on malaria for those that have fever? Can we also on that outreach provide TB screening for people? So there's a lot that needs to be done as far as collaboration is concerned for us to have a resilient health sector. Thank you.
Thank you very much. Now on to our brother and friend from the right place, health. The place of research and community engagement. If it's all about the community, to what extent should the community be engaged in ensuring that we have this healthy and resilient environment? The place of research and community involvement.
Thank you again. It's a privilege to be here and to air our voices to these endemic challenges that we have in Africa. The professor did a good job presenting his paper. And the place of research, he also alluded to it, cannot be underestimated in this discussion. He mentioned that Africa has about 15% of the world population, but can only boast of 2% of research. That's ridiculous. And then also when you begin to look at some other indices and some other health indications, you notice that when it comes to like something like neglected tropical diseases or some of the waterborne diseases, we have like 39 to 40% of the burden, global burden. Last year I was in Nigeria, spent a month at the National Institute for Policy and Strategic Studies. I just came out of curiosity to ask questions. So at that one of those sections said a resource person, a doctor, came to talk to us at the institute, and he was quoting numbers and statistics from the US at the National Institute. And I was angry. I was uncomfortable. So at some point I raised my hand and said, I have a question, sir. I said, are we in the US or in Nigeria? He said, we are in Nigeria. I said, okay. I live in the US. I flew all the way from the US to spend a month here. Why are you telling me things from the US? I probably have better access than you do. He said, we don't have data. Well, maybe we need to stop this class and go get data. Because it does not make sense that we're going to be making policies at the National Institute for Policy and Strategic Studies using data from the United States. That is ridiculous. But that is our reality, unfortunately. And why is it so? When you go to the United States, the rest of the world, Africans lead in all these departments and sections. In every area of endeavor, Africans are top in their professions. So when you talk about research, we know better how to do research. We have people who are experts in those fields, but they are all over the places. So if we have agile leadership, like the professor said, and we're able to attract our people and give them support, a little financial backing, we should be able to generate even more data in Africa to sustain Africa. And I think that is the call of the moment, that every one of us must figure out ways that we can use the skills and the manpower and the resources we have in Africa, generate enough data in Africa to be able to address the challenges we have in Africa. If we are waiting for the West to do it, it will never happen. Because they are still struggling with their own issues in any case. And sometimes you find out that even the little support that we have are not being properly managed and properly implemented. So if our people are honest by ourselves, all of us here, and people that we know their names and their surnames, if we are honest with the assets that we have and the little resources that we have, research should get a lot more attention, and the output of those research can help to influence policies and practice within the African space if we are really serious about building resilient Africa. And what was the second question about research? Community involvement. Of course, we used to talk about community participation. No, now it has to be ownership. Some level of ownership has to be involved. So, for example, and again, it goes back to what I was talking about in research. If we are waiting for funding, part of the reason the World Health and some of their partners' commitment to fighting neglected tropical diseases and waterborne diseases that are prevalent in Africa is failing is because they don't have, even when they have funding, they are not enough, but also your fund that you have will not go a long way until and unless there is community, not just involvement, but ownership. And sometimes for the community to own this project and to protect this project, they have to have their skin in the game somehow. So if our own local governments, our states, our federal, whatever we call them, make these things priority and they have their own skin in the game, whatever else support that we get from elsewhere, we now augment what we have. And then we'll more likely be able to protect what we have. I give you an example. If I come into a community and I feel like they don't have good water system, and we put water system for them, they're supposed to supply them with potable water. If they're not part of that project, chances are that they will not even protect it. And it happened in my own community, so I'm not talking about something foreign. So if the people have not bought into this project, and they don't have a skin in the game, and they don't see it as important as you come preaching it, chances are that they will vandalize it overnight. I came into my village with a group of people, and we found out that they don't have light, and they don't have good water system. So we came together, put some money together, put light for them, and put water system for them. 1 month after, some idiots vandalized the whole life. I mean, the village is back in the darkness. So how can that be food like that? So you see that on one hand we need research, yes, but on the other hand, even the research and the research process and the process and the outcome, the community has to have some kind of involvement and ownership. Otherwise, it will not be sustained. Thank you very much.
Let's appreciate him. As we wind down, let's have this understanding that something went wrong someday, sometime. And that's the reason why we are all out to see what we can do to make it right. We might begin to ask ourselves, because I've just asked them to give, I wouldn't say last word because you are not dying now. You just say one or two things and then we run off. I would really prepared, and we are preparing to break even. So it will not be the same story next year. We've had a story from Borno State. We had a story from Rwanda, from other countries. Is it going to be the same in the coming year, even tomorrow? Now, we talk about the issue of mental health. Of course, I came with a colleague who is a mental health specialist. That's one of the reasons why in the last 5 years since our path crossed, I celebrate to my friend Emmanuel Anyebe. Since the last 5 years our path crossed, we have been, every day, the friendship gets thicker and thicker. Because I find that this issue of mental health, we play it out as if it's not part of it. Now, without doubt, there are Prof mentioned while he was rounding off, and as if, of course, when Professor Atul Loma spoke in the morning, you will see a synergy between his lecture and his lecture. Now, and Prof said while he was rounding up, he was talking about multifaceted strategy approach. I'm going to be asking you one by one as we wind down. What will you suggest that we require as a take-home for all of us from this place and from academics? But my own duty is just to teach. Most of the people I teach is like I'm teaching for exports. I can't stop them. The environment is not conducive for them to work. Some of us, we are here, we are pharmacists. We do it in our own little community. That's the much we can do. But of what, what impact can we do, or can we get beyond that? And so, journey to a healthier and resilient community is possible. I say it again. Journey to a healthier and resilient community is possible.
We can, with the understanding that we have, ensuring that the basic things that are required. For instance, we are here, we have bottled water on our desk. There are places that you go to. This bottled water will be, what will I even say, for the elite high up there. Whereas we can still make this bottled water available not in bottled water package form, but in a borehole form that people can easily access. Can we start with those little ones before we get to the ones that will demand so much? Thank you.
Thank you, sir. Dr. Samsudeen.
Yes, I think I quite agree the two presentations we had today, they are quite interrelated, and it shows how weak our health system is with the inequality and of course with the new challenges. For me, what is lacking is there are so many things, but we need to strengthen leadership and governance. For those of us that were in the Ekiti, the National Council of Health, we have seen the new leadership. There's going to be a paradigm shift from the business as usual. Everybody is going to be held accountable. You know, our partners, government, NGOs, civil society, everybody. And looking even at the larger picture, during the retreat for ministers in Nigeria, we've seen what the president has said. There is going to be accountability framework. Everybody is going to be accountable. If you are a minister, you must deliver. If you are a permanent secretary, if you are a head of parastatal, there has to be that accountability, you know, performance management. This is the only way. If people are held accountable, they should be able to deliver. If you cannot perform, then you simply move. So it's quite in aligning with the health system, strengthening leadership and governance. We need to make sure that we hold people accountable. There is, you know, leadership and governance accountability framework. Everybody must do his own bit to ensure that we move and have a strong and resilient health system. Thank you.
Thank you, sir. Before Registrar speaks, Oga said holding people accountable. They will promise you bridges where there's no water, when there's no river. At the end of the 4 years, nothing to show. These are the things. I mean, I can imagine if Professor Baba Gana, who stood up to speak of his governor, is serving now as a commissioner. I wonder what, I'm sure he will do, if I will say a better job, that means improving on what the governor has done if he becomes the governor. That's the way it's supposed to be. People prefer to stay in the urban now rather than the rural area. Why? Because life is there. But if you go to the rural area, life is much more better. The environment is conducive, serene. You sleep with your 2 eyes closed, not like urban area. So we will get there by the grace of God. Oga Bankole, we are talking about achieving a healthy and resilient community. Something we can have. What multi-system approach are we putting together as RAN, which we will take home as a working document? People have mentioned their own. We just want you to contribute yours before we say the last.
Anyway, it still boils down to the governments, you know, the commitment of the government in turning around the healthcare system in our country or in our countries. The other time I was traveling to for a conference in Cairo. You know, I did small research at the airport in Abuja. As we're coming in, as we were boarding, I was asking questions. What are you going to do in Cairo? Most of them, they are medicals. They are medical is because their government believes so much in having a robust system for them. So everything still boils down to governments. You know, you see, we train our health worker in Africa. We lose them to Africa, to Europe and to America. A system that does not remunerate, you know, the health worker well. Of course, they are not missionaries. They are to be. They are working so that they can be taken care of. So the whole thing still boils down to the government. Thank you very much.
Thank you. The place of motivation. Please let's stand for him. The place of motivation, it's been well laid out. And you see, an NGO will take up a program in a community and they'll be doing very well. And the government will find it difficult to do. The same terrain. I work with an NGO, and it's the village. Everything that we needed to be comfortable was made available for us. We were working there for 7 years, no hustle and bustle. But when they ended up and they handed it over to the government, within 3 months, it failed because people were just trying to have their own share of it. Well, while you are getting set to take your leave, I'm told that one of the new, my God will help me. Please, just brief comments, then.
Thank you very much, sir, and thank you to our panelists. The question you just asked from them, the last question about where do we go from here, so that we don't keep on repeating this each time we come for a conference like this. And my mind, just like my sister had rightly said, went to the common definition of health that WHO has given us. That is this complete state of well-being, physical, mental, social, not merely the absence of disease or infirmities. That means that we don't have to concentrate only on when somebody is sick. And when we are talking about that, we need to look at the total, system of a
of a person. She mentioned environment. She talked about collaboration. And here, there's something we have not really mentioned well. We have not deliberated upon very well. And that is information. And information is key. What I see is one of the major problems amongst us in Africa is misinformation, which is brought about majorly because of our cultural beliefs. Something happened about 2 weeks ago in our institution. There is one of our lecturers that lost family. So suddenly we heard that this man was in the ICU. What happened? They said, one solata in Yoruba, they said they must have shot him an arrow. Then I asked them, arrow, how? Was he fighting with somebody? He said, no, he just had something like a wound on his lower leg. Immediately my mind went to snake bites. So I asked the question, I said, did he go to the farm? They said, yes. When did this happen? They said it happened about 2 days ago. And the knowledge I have about those is, those snakes, they are usually the one that paralyze the nerves and the one that will dissolve the blood. So I said, how is the man feeling now? He said, he's not delirious. And when we went, eventually he died. They said, what happened to him? He cannot take it to the hospital. That is supposed to be treated somewhere because it was a magical arrow. So I asked the question, I said, was there hemolysis when the man was about to die? The man said, what? I said, was there blood coming anywhere? Because the neurotoxin kill almost immediately, but the other type will take some time. So I now asked, he said, yes, blood was coming from his mouth, from his anus, from his head. And I said, oh my God. What did the leg look like? He says, like they pour hot water. The doctors here, they know what I'm talking about. That is just the symptoms of snake bite. But because already they had it in their mind that somebody shot arrow, invisible arrow to him. And this is an educational, a tertiary institution. People you are supposed to know better. And so we have this problem about cultural beliefs too. Our people believe there are certain type of disease that you don't take injection. You don't take people to the hospital. That is there. Even when you give them drugs free, some will run away. They will not take it. They need information. We need to inform them so that they will know that this misinformation is just giving them a problem. So where do we start from? They say, well, if you want a change, we must start from ourselves. I don't know how many of us, thank you, sir. When you came on board, you said we should stand up, stretch our hand. I don't know, this is November 22. I don't know how many of us have done medical tests this year. And we have this array of medical tests. We have the one for women, we have the one for the women, the one for the men, that we are supposed to be doing every year, at least twice, doctor, isn't it? At least twice we should go for them so that we know the state of our health. So let us start from ourselves. Then we'll be telling our neighbor, telling one another. Then we'll be moving towards this healthy and resilient community. And the last thing I want to talk about is that we should involve everybody. Town planners, our cities are filthy. We are so happy to see Kigali beautiful, Rwanda. Everybody is talking about Rwanda in the world. That is where we should be going. Our towns are so filthy that what are the town planners, what are they doing when it comes to sewage and refuse disposal? So everybody must be involved. The NCC, the television station, and we as health professionals, we should not keep our mouth shut. We should be giving information as at when due. Thank you very much.
Thank you. Let's clap for her. You recall also that when Prof came up for his lecture, I was asking myself, we've been leveraging on WHO of Health 1948 or so. For how long with that? I teach it every time I'm talking about primary health care. But Prof gave us a new concept. Please, again, we celebrate you, Prof, sir, for that. Please, let everybody get this paper, sir. So please, because I committed myself to him, please, just.
Thank you. I haven't listened to the eloquent presentation and the contributions from the crowd. I was looking inwards and I thought that we have the privilege of an array of professionals in the whole of Africa gathering every year somewhere in Africa. But beyond that gathering, we then go back to another year. What are we taking home from today? I think we should go beyond just the conferences into clear advocacy back in the countries where we are from. We need to do more advocacy, intergovernmental exchanges in our advocacy as an institute, so we can bring to bear the ideas that we're putting together. Otherwise, we just have these beautiful ideas in our briefcases, and then we go back home with it. Thank you very much.
Please, we have to go. We have to go. We have to go. Please, I want to plead. I want to plead. I'm still pleading. I'm bending and doing exercise. Please, if you still have anything to put down for us as a take-home, please write it down. It will really help us. So I will pass it to the organizers. We must start somewhere. I must start from us. Again, let's appreciate the panelists for coming on board to do this work. Thank you very much.
Thank you, thank you so much. Thank you, Doctor.
The MC, please.
Thank you, sir. I know that our time is fast spent, and we all want to go home. But please just bear with us for the next 10 to 15 minutes, and I promise you we'll be all out of here in the next 10 minutes. Or less than 10 minutes. The last speaker of this evening is Dr. Yakubu. Please, you can come and have your presentation. Please, please. Yeah, clap for him, please, as he takes the stage. You stand there.
Stand here and see the slides. Thank you very much. Like the MC said, it's going to be a short presentation. It's my ORAS presentation. I have to give it today because I will be leaving for Nigeria tomorrow. I have my convocation. Thank you for giving me this privilege. My name is Dr. Yakubu Dauda Izang. I work with Plateau State Primary Care Board. I am supposed to present with my mentor, my boss, Professor Mukhtar Mustafa of the Department of Economics, Bayero University, Kano. Now, we conducted a research on the, next slide, on the throwing out practices of colostrum among breastfeeding mothers attending postnatal care services in Plateau State, Nigeria. Next slide. The objective was the study investigated throwing out practices of colostrum among breastfeeding mothers attending postnatal care services in primary health care centers, Plateau State, Nigeria. As you are all aware, colostrum is a nutrient-rich first milk produced by the mammary glands during pregnancy and is released after birth. It is a nutrient-dense, easy to digest with high antibodies and antioxidants to build up a new baby's immune system. So you can see the importance of colostrum. Now, next slide. 3 specific objectives with responding research questions and 2 null hypotheses guided the study. These objectives are determining throwing out practices of colostrum among breastfeeding mothers attending postnatal care services in primary health care centers in Plateau State. That is a specific objective 1. Then the second one was throwing out practices, investigate throwing out practices of colostrum among breastfeeding mothers attending postnatal care services in primary health care centers, Plateau State, based on age. And the third one is to investigate throwing out practice of colostrum among breastfeeding mothers attending postnatal care in primary healthcare centers, Plateau State, based on educational level. Next slide. Now, I told you two hypotheses guided the study. The first is there is no significant difference in the throwing out practice of colostrum among breastfeeding mothers attending postnatal care in primary healthcare centers, Plateau State, based on age, and the other one is based on educational level. The study adopted a descriptive survey research design, and population for the study was comprised 1,703,764 women in Plateau State. The sample size for the study was 300 breastfeeding mothers, and the instrument for the conducting the collecting data was a researcher designed throwing out practices of colostrum questionnaire. Next. Now, validating the instrument, the first validity of that instrument was established by 5 experts. 2 were from Department of, Primary Health Care Board, Reproductive Health Section specifically, and the other 3 came from Reproductive Health Department of our specialist hospital, which is a tertiary institution, Plateau Specialist Hospital, respectively. Now, the reliability coefficient, which is the internal consistency of section B of that instrument, was determined using the Cronbach alpha statistics. Now, the SPSS, the Special Package for Social Science, version 25, was used for the analysis of quantitative data. Next. And for the reliability, and the coefficient for that section B of the instrument was 0.83, and mean and standard deviation were used to answer the research questions, and null hypotheses were tested using one-way analysis of variance and over at 0.05 level of significance and appropriate degree of freedom. The quantitative data showed that 198 breastfeeding mothers, which is 66%, expressed and threw away colostrum and never gave their children the first milk. So you can see the results. Next. All right. There was a significant difference in the throwing out practices of colostrum among breastfeeding mothers based on educational level. Based on the study's findings, it was finally recommended that among others, that throwing out practices of colostrum education campaigns should be intensified at the primary healthcare centers to improve breastfeeding mothers' practices against throwing out of colostrum in Plateau State. Thank you very much for your time and patience.
Thank you, Dr. Yakub. We call for questions. We can get just 2 or 3 questions in the interest of time. 1 minute.
Thank you very much, Dr. Yakubu, for a very good presentation. Soma, I raised my hand for you. So, number 1, I thought we will see the justification for this research.
Okay.
Number
okay.
2,
yes, justification.
Clearly what are the research questions. Number 3, in your methodology, I've not seen the sample size, how you arrive at the sample size. Then the sampling technique. What sampling technique did you use? You did not inform us whether you have ethical approval. In the results section, we've not seen whether there are tables and, what are your outcome variables. And, let me stop here.
Okay, thank you very much. This is oral presentations. This is oral presentations. In the magazine for public health professionals, you see all this. But let me attempt to answer some of your questions. The sampling technique was a multi-stage sampling technique. 3 stages were involved. First was the balloting without replacement, the simple random sampling, and to select 10 local governments out of 17, because Plateau State have 17 local governments. So that simple random sampling using balloting without replacement was used to select 10. And the second stage was also a simple random sampling using balloting without replacement to get 10 primary healthcare centers. I thank God for Professor. He said in the Borno State, all the wards have primary healthcare centers. So in Plateau State too, we are trying our best. I think about almost 11. So we're left with 6 now to establish primary care centers. So that was the stage 2. And the third stage was a purposive sampling technique to draw out 10 women from those primary care centers and to make up the 300 sample size. And the other question you were talking about, sorry. Yes, that is how I arrived at the number, the sampling technique. The size is 1,700,000 and something.
Just note it, young man, note it.
Just note it.
Well, I think mine is just to go to your conclusion. You said, what is your conclusion? What do you think is the conclusion of this study without looking at that as me being somebody who doesn't know what that means? At the end of this work that you have done, what do you want to tell us that is new? All right.
I want to tell you here that it's a pitiful situation. About 66% of this population are expressed and throw out breast milk. So it's a pitiful situation, and therefore there is need for awareness creation on the importance of colostrum, which is a very, very important first milk that gives protection to the newly. Thank you.
Thank you very much. Mine is actually a comment for when did you do this research, please?
Yeah, I conducted it this year.
This year, 2023.
Yes, sir.
So, ladies and gentlemen, believe with me that we are really trending backwards. If by now awareness on the importance of cholesterol has not gone to our people, and we are getting 6% from this research, that means we have a lot to actually address. And no wonder our infant mortality rate is actually very high. So these are the deep dive issues that we have to actually address as public health physicians. And not...
I'm not a physician anyway.
Yeah, you are not, but most of us are public health physicians. And
public health
to be very frank,
it's also important.
Information, this counseling we've been always talking about, awareness, and antenatal care visits, the health talks that we always talk about at primary healthcare levels are actually at apathy. That is exactly what the research is talking. If we are to actually dig it down, you realize that most of your clients have failed in attending antenatal care. And about 90% of them did not even deliver at any healthcare center. And this is actually where we have the jeopardy and the challenge. Part of what I wanted to actually say during the conversations in the morning and this afternoon was that it is high time in Africa we prioritize efforts in seeing that all medical officers should get back to primary health centers. Let us equip our primary health centers. Let us make it functional. All medical officers, I'm not saying few, I said all. There is no point in a tertiary hospital, you will say a medical officer, what is he or she doing there? Let's be very frank. It's a tertiary center where we always have what? Specialists that will address what? Complications. How can we be treating malaria in tertiary hospitals and we say we want to progress? Progress where? Let us go back to maintain our primary health centers, all medical officers back to that place. Let it be functional. Everyone have primary health center equipped with doctors, nurses, laboratory scientists, physiotherapists, and so on. Let us be doing the real work. So secondary health centers and tertiary centers will now be our reference centers. And if we do so, in fact, it should be the role of Federal Ministry of Health now to medical doctors back to primary health centers. Let them collaborate with the state primary health care agencies. And their salary should be the same with federal level. When we do this, like this empowerment, and we will actually have a very fair understanding and flow of how we address our health inequalities, and we will function better. Thank you very much.
Thank you, Dr. Dawood. He's a friend of Plateau State, and he knows Plateau very well. Thank you very much.
Yeah, thank you, Dr. Yakubu.
Thank you so much.
Thank you so much. Thank you for your presentation. Now, standing on the existing protocol, you permit me to invite the last speaker who is going to give us the closing remarks and usher us to the evening tea. This is the last time you will see me on this stage for today. So I'm not going to talk again. So let me hand over the microphone to the Secretary of African Institute of the Public Health.
All protocol duly observed. I want to thank the organizers, collaborators, and partners, including the participants of this conference for today. I believe that our contributions have been informative, and it really helps us as Africans to achieve healthier and resilient communities. Thank you very much for all your contributions. Thank you, and have a wonderful night rest. Good night, and see you tomorrow.
Please, as we proceed out, there is an evening tea at both ends of the gate. You can have some as you interact and say your goodbye.